Actually,
And
I was not getting a very good platform. I had got the platform of MP Isar, but MP Isar has joined up with Dr. Kavita Bapat. Dr. Kavita Bapat is a very good friend of ours, but you can choose only one of the two. And Randhir and I, we are not the people who will say yes to her and yes to her.
correct.
We have to take a stand when we are, when we are at this stage. So Dr. Sunita, then she gave me the ISAR platform. So we thought the ISAR will be a very good platform to not only for the web series, for our speakers, for the attendance, as well as for madam's election.
Correct. So I gave cards and everything to their HOD in Srinagar Medical College.
It is 4 o'clock, I think, Vishal. It is 4 o'clock.
It is 4, yes.
So let us, Dr. Girish, will continue the conversation.
Mr. Ronak?
No problem.
And Purnima, have you informed Sunita, madam?
Ma'am, can we just go live?
Yes, please.
So just allow me, ma'am, 30 seconds before I give you a countdown.
Sunita, madam has been informed, Purnima?
मैम मैं कॉल कर दूं एक बार आपको.
मैडम को कॉल कर दो एक बार.
Yes, ma'am.
Ma'am, we are live in 3, 2, 1. We are live now.
Good afternoon, everybody. As usual, we welcome you all in this perfection series under the central banner of ISAR. Myself, Dr. Vishal Dave. I am medical advisor in Intas Pharmaceuticals, and on behalf of Intas, I welcome you all. Today's topic is nuances of fetal medicine and obstetric Doppler for the obstetrician and gynec practitioner. The co-convener of this session is Dr. Monica Singh. Dr. Monica Singh has been awarded 10 gold medals. She is also professor at Allen Medical College, Bhopal. She is consultant reproductive medicine, Bhopal Fertility and Endoscopy Center. She is honorary secretary, MP chapter ISAR. She is also the vice president of Bhopal Obstetrics and Gynec Society and Bhopal Menopause Society. It's my pleasure to hand over the session to Dr. Monica Singh. Over to you, madam.
Thank you. Thank you so much to Intas Pharma. And thank you to all our esteemed speakers, Dr. Manish Pandya, Dr. Mayank, Dr. Girish Patel, and all the panelists and our esteemed moderator, Dr. Aparna, for being with us today. And this webinar is about a very important subject of fetal medicine. And we all know that genetic carrier screening, prenatal screening for aneuploidies, and prenatal diagnostic testing have expanded dramatically over the past 2 decades. So this is actually being driven by powerful marketing also, you'd agree. But new complex modalities now testing have become available only after very limited clinical research. Sometimes I feel that these companies are coming up with tests which obstetricians don't understand, which the patients do not understand at all, and there is no research backing it up. So the responsibility of offering these tests to our patient actually relies on all of us. So genetic testing in pregnancy is totally optional. That is, like, I have also done a lot of reading before this webinar. So this is totally optional. Decisions about undergoing the test, follow-up testing should be properly informed to the patient and based on the couple's decisions, needs, and choice. Although a plethora of new genetic testing modalities have become available because of the fueled by the intensive marketing, the information they provide actually may be ambiguous, complicating the decisions they provide and raising ethical issues. Therefore, pre-test and post-test counseling are of vital importance, and this will be discussed in the panel also. In order to provide optimal patient care, it's essential, therefore, for us obstetricians to stay up to date about our knowledge regarding available technologies and the benefits and limitations of each test, which is difficult but not impossible, because in each of us, there is still an MBBS student who is wanting to know, who's wanting to dig his or her, heads in the books and learn more. Fetal ultrasound. Good evening, ma'am.
Hi, good evening.
Thank you for joining so punctually, Sunita, ma'am. That is your USP. Always there.
When you have dignitaries like Dr. Ashok Khurana sir, I can't dare to be not punctual. I see Dr. Milind Shah over here. I see Manish Pandya over here. This perfection series is always star-studded, and you need to be absolutely punctual because it is highly viewed.
Thank you, ma'am.
Yeah.
Thank you so much. So,
Great,
ma'am,
great, Sunita. Wonderful. Good start.
So, ma'am, just the last few lines of my intro. The fetal ultrasonography is a standard and vital component of comprehensive fetal evaluation in pregnancy. And based on maternal and fetal risk factors, ultrasound timing and frequency are individualized according to the inverted pyramid of care, which will be brilliantly described by none other than our star speaker, that is Dr. Sunita Tendulwalkar, ma'am. So I welcome you all, and we start this 4th episode of ISAR Perfection series. And I would like to begin by welcoming our ISAR president, Dr. Nandita Palshetkar, ma'am. Can I have a CV? No, Dr. Vishal? Now, madam will be joining. She has 2 important talks, and so she will be joining. Sunita ma'am, she'll be joining after 5:30 or 6 p.m., but she'll come and give her presidential address. There is nothing to speak about Nandita ma'am except that she has been a leader throughout. At the national level, President ISAR at present, President FOXI 2019, President IH 2017-18, state level President of AMOX, and at the international level, she has been the FOXI representative to FIGO, member of the FIGO Committee on Health Systems, Strengthening and Respectful Care, FIGO project head of PPH. She is also the member of several important Maharashtra government committees,
Ayesha?
the State Supervisory Board of PCPNDT, Uterus Transplant Committee, ART and Surrogacy Committee. And madam has received so many awards, and I'm totally indebted to Nandita ma'am for giving us this platform to present Perfection series. My welcome would not be complete without acknowledging the complete support of Dr. Sujata Kar, our Honorary Secretary General of ISAR. And madam is also a very accomplished practicing gynecologist, endoscopist, and a practicing assisted reproduction for the last 7 years. She's a brilliant academician whose special area of interest is PCO, proteomics of male infertility, and stem cells in gynecology. Lastly, I invite and welcome Dr. Sunita madam. Dr. Sunita Tendulwalkar, there is nothing to talk about madam except that she is the most brilliant dignitary amongst us today. Madam is the president, POGS 2122, the convener and the brainhead who spearheaded this program of ISAR Perfection series. Because of only her support, we could go forward and present our program on the national level. Madam is Senior Vice President ISAR, President IAG 2019-20, Vice President West Zone FOXI 2015-17, elected board member of ISG 2013-17, and has received so many awards, including a letter of appreciation from President of India in 2012. Madam has had, and her center, SonoCell, has achieved the extraordinary achievement of giving us the India's first stem cell baby, the world's first, at the age of 45 on 16th of April 2018. And we have heard brilliant things about stem cells and endoscopy from madam in every webinar. Thank you, ma'am, so much, and most welcome. Next, I would invite my co-convener, Dr. Randhir Singh, who is ASHRAE certified embryologist, Director of Bhopal Fertility and Endoscopy Center, Associate Professor, Ellen Medical College, Bhopal, organizing chairperson of the 27th Annual ISAR 2023, which recently concluded in Bhopal. And he would be inviting our chief guest and guest of honor who have already joined. Dr. Purnima, is Dr. Randhir there? Okay, so I will be inviting our chief guest. It is my immense honor and pleasure to invite amongst us Professor Ashok Khurana, MBBS from AIIMS New Delhi, MD in radio diagnosis from AIIMS New Delhi, which is at the pinnacle of all medical institutes in India, trained at the Herlev Hospital in Denmark in ultrasound, Sir is chairman and consultant in reproductive ultrasound at the Ultrasound Lab, New Delhi, and practicing in Delhi since 1980. He is also the professor, School of Health Sciences, Dubrovnik International University in Croatia, professor of IMA 2017 to 2020, past president of the Society of Fetal Medicine, SFM 2018 to 20, former ISUOG ambassador in India, former dean of Indian College of Medical Ultrasound, ICMU, mentor emeritus, Society of Fetal Medicine, editor-in-chief, Journal of Fetal Medicine. Welcome, sir. And we would really like to hear from you about your views about these educational programs, about your work, and about what you think fetal medicine can do in India, change the women's lives in India, and in what way. Welcome, sir.
Thank you very much, and thank you for making me a part of this event. It's a pleasure to be here in the company of so many friends, and it's wonderful to have Dr. Sunita Tandulwadkar here this afternoon. I've always admired the way she combines academics with glamour because it makes academics more attractive. And when anything becomes more attractive, you tend to carry it in the mind. And that really is the essence of what we will be discussing today. Because we do realize that when a patient comes in for infertility, we don't promise them a pregnancy. What we need to promise them is a healthy baby. And yes, I agree with you, Dr. Monica, that yes, there has been marketing and things like NIPT, but there's been a lot of evidence to also suggest that most parents would like options, that even if it's a precious pregnancy like an IVF pregnancy, we need to take special care. We need to give them the options of whether they would like to have a baby with the most common cause of mental retardation, such as Down syndrome, and whether we're able to deliver these babies at the right time, because they're often high-risk pregnancies. Our IVF group particularly often have a background of either advanced maternal age or polycystic ovaries, and we know that these by definition are very high-risk pregnancies. Whether they would like to have a baby with the most common cause of mental retardation, such as Down syndrome, and whether we're able to deliver these babies at the right time, because they're often high-risk pregnancies. Are you able to see me again?
Yes, sir. Yes, sir, we are.
Okay, because I'm getting a double reason for some reason.
Yeah, we are getting an echo. So,
No,
support?
this is the live recording which is there, that is placed.
Yes, that seems to be.
Yes, recording which is done at the back, that is played.
Okay, and now are you able to get me clearly?
Yes, sir. Yes.
So to come back to where I was, there are these situations where we do need to make decisions during pregnancy, and we do need to make sure that the whole effort that we have gone to in making that baby should also be realized by making sure that we give them a healthy baby. And so I'm so glad that we've blended our fertility societies, the Indian Society for Assisted Reproduction, and our great speakers in fetal medicine today to give us answers on inverting the pyramid of care for the first trimester scan in post-ERT pregnancies, where we do require to be very aware of the fact that there are nuances in this. We have an excellent talk coming up on how to do the anomaly scan, and of course, the role of colored Doppler in timing delivery for fetal growth restriction. I'm glad that there's going to be a panel as well to put all of this into perspective, and I truly look forward to a great evening of academics. Thank you very much once again for having me here.
Thank you, sir. So after this beautiful introduction to the topic by Professor Ashok Khurana, I invite our chief guest for the evening, Dr. C.B. Nagori. There is no introduction required for Dr. C.B. Nagori, who is such a prominent figure as far as infertility ART practice in India is concerned. He is director, Dr. Nagori's Institute for Infertility and IVF in Ahmedabad, India. He has presented the best paper in the World Congress of ISUOG in 2008 Chicago, first stem cell pregnancy in India, first ever Center of Excellence for Ian Donald School of Ultrasound. They hold regular trainings in their center in infertility, IVF, and ultrasound. Sir has held Gujarat University recognized fellowship programs in infertility in IVF, published several papers in index journals, and contributed in and authored several books. Welcome, Dr. Nagori, sir. And we would love to hear your views about today's webinar and what is your vision for our country.
Thank you very much for inviting me today. I really appreciate the academic program which are going on. And as such, there is always a scarcity of the good academic programs. And I think webinar is one of the best way to give the education to majority of the doctors. The only thing is now the fetal medicine is very important because majority of the cycles are going for ART, are going for the freezing cycles. And all of us know that the recent data is that when you go for artificial cycle, then the incidence of large babies, incidence of PIH is very common because of the absence of copper luteum. And that's why in all these conditions, the follow-up of the pregnancy is very important. I appreciate such programs, and I wish the brilliant success, especially thanks to Dr. Sunita as well as all the organizers, Monica, Randhir and all. I'm thankful to Nandita madam also for organizing such type of programs, and I wish the brilliant success. Monica, congrats to you and Randhir for excellent effort done by you. Thank you very much.
Thank you, sir. Thank you, sir. Our chief guest for the evening is none other than Professor Sudha Prasad ma'am, who is a well-known figure, in the Delhi scene of ART, a pioneer of starting IVF in Maulana Azad Medical College, Delhi. And she is MD OBGY from AIMS New Delhi, Director Matritva Advanced IVF and Training Center, New Delhi, former professor and IVF coordinator, IVF and Reproductive Biology Center, Maulana Azad Medical College, Delhi. She has a teaching experience of more than 38 years. She was the former Dean Faculty of Medical Sciences of Delhi University 2015-16, has received State Award by Government of NCR Delhi for doing meritorious services in the field of healthcare in Delhi in January 2003. She's been awarded short-term fellowship to Hungary under Indo-Hungarian Educational Exchange Program in July 2006. She is Member Secretary, Independent Ethics Committee, IFS, past president of the prestigious Indian Fertility Society in 2020 to 22, past vice president Foxy 2019, and has given more than 65 national and international publications and written several chapters in various books. We are honored to have you amongst us, Dr. Sudha Prasad ma'am. Has madam joined us? Dr. Purnima? I think madam has not joined us.
I don't see her.
So ma'am, I hand over the program to my coordinator, Dr. Purnima.
Before that, can I say just hello to Dr. Ashok Khurana and Dr. If you stop the screen sharing before they log, it's lovely to see the two legends of the country. Can screen sharing be stopped? You know, ये login करके चले जाते हैं. कौन सी कंपनी के लोग हैं?
It does, madam. It does.
Ma'am, I just talked to Sudha Prasad ma'am. Ma'am is busy right now. She is somewhere outside India.
No problem.
She will try to join as soon as possible.
Okay, Purnima. Thank you.
No problem for us. We just want to say hello to people and dignitaries who are here. I can't see when someone started sharing the screen. Dr. Vishal Dave, stop screen sharing, no?
Dr. Vishal, please stop the screen share. Yeah, let us just...
I can't see Chaitanya Nagori sir now. Okay, anyway, so, and I wanted to congratulate even Monica. Chaitanya sir is here. अरे क्या सर आप इतना टेक्नो सेवी है, सिर्फ फोन नंबर लिखते हो. आप डॉक्टर चैतन्य नागौरी सर लिखो ना आपके इस पे आईफोन पे. I'm just joking. He is our great friend of ours and lovely to see you all after a long. Chaitanya and Ashok Khurana के साथ बहुत webinar में मुलाकात नहीं हुई है मेरी.
True. But this is so wonderful to be all together again. And I'm really looking forward to an excellent topic and excellent presentations.
And we cannot reach Ashok Khurana, sir, without going through his secretary and, so it's very difficult to approach Dr.
No,
Ashok.
no, no. Khurana sir gives appointment to my patient immediately. All my Delhi patient any night, I said, just Dr. Khurana ka ye number hai. I share the number and he works for them.
I
Thank-
absolutely echo that, because whenever I try to, connect our patients to him, it happens immediately. Great.
Thank you.
Monica, I will tell you the trick.
Manish wants to say something.
If you want to reach Dr. Khurana, just give him the WhatsApp. Even at the night 2:30, he will reply.
Then,
Don't
sir, I
do
don't
him
have
too
your
much.
right
Just
WhatsApp.
give the WhatsApp.
This is live relay. Lot of secrets are getting revealed, sir. Your whole night will be now damaged.
No problem.
Dr. Bhojwani, I'm seeing you after months and
Yeah. Hello. How are you? Oh, but you
very
are not.
fine. Dr. Girish Patel,
Hello,
Vishal
ma'am.
Dave, I keep on seeing you at least. Hi.
Namaskar.
Lovely
Namaskar,
to
ma'am.
see you. Lovely to see you. We can start.
And
Yes,
there's
all the best.
not a single person that Sunita madam misses. Sometimes I'm seeing here and there who all are there, and madam has already spotted who is absent. Ma'am, you are really very sharp, very sharp.
Endoscopic view रहता है हमारा.
No,
Your
Sunita ji,
stage, madam.
this is
And
presidential view.
that to 30 degrees, not 0 degree.
Yes.
Presidential view.
Totally presidential view. For us, madam is unopposed.
Great.
Dr. Khurana sir, there is an election. Don't carry wrong impression. You don't have a voting right, but your blessings are important for me.
I'm on the voters list, by the way.
Acha, you are on a Foxy voters list?
Yes,
Yes.
yes,
Sorry, Dizio.
yes.
Yes. I'm one of the
Wow! I got superb,
Oldest
superb, sir.
member.
I'm one of the oldest people on Foxy, by the way.
Oh, I never knew this. See,
Madam,
this
every
is why
vote
the
counts.
webinar should be attended. I got one more vote here. And Dr. Khurana has hundreds of followers across. He will post it. His status will be, I voted for Sunita. Have you?
Yes.
And I've been a member of Foxy for 42 years now.
Thank you, Ashok sir. Thank you for letting us know that. Thank you.
So madam has given across the point that every member of Foxy matters.
Yes.
She talks with same affection to the junior most, to the senior most.
That is our nature.
Yes, ma'am.
That doesn't come with Foxy. That is our nature. Irrespective whether you are in election, every member is respected, because even my junior most new intern also teaches me a lot. You need to observe. You learn a lot from them also.
Yes, ma'am. Perfectly said. So Dr. Purnima is our program coordinator. Can I have her slide, please, Dr. Vishal, and then she can take the program forward. Dr. Purnima is a very active coordinator, madam. She has recently shifted from Nagpur to Bhopal, and it was Nagpur's loss and Bhopal's gain.
Yes, Purnima. She gave me a call also. I was trying to log in only.
So can I have a slide, Dr. Vishal? Technical people? I would just like to say 2 words about her, though she's a very dynamic girl, and she moved from Dr. Chaitanya Shembekar's IVF Center to Bhopal. And she has now started coordinating with me for all the academic programs and so many other things we are planning. So slide, please. Vishal, are you there?
Yeah, I saw Vishal.
Yeah. So it's my pleasure to invite my dear junior Dr. Purnima Tiwari, and she has got great credentials to her credit. Alumnus, Lady Harding Medical College, Delhi, MS OBGY from MAMC, Delhi, and she has done fellowship in minimal invasive and laparoscopic surgery, robotic surgery. She has trained in gynec oncology. She has also received the Foxy Traveling Fellowship, ICOG Fellowship in Reproductive Medicine from Omega Hospital, Chaitanya Shembekar, Nagpur. She has also done Advanced Diploma in ART in Reproductive Medicine from Germany. She is Associate Member of Royal College, and she has done several publications. In fact, Sunita ma'am, the last webinar on female genital tuberculosis panel, she presented her own case of cervical tuberculosis, which she had seen and treated in AIIMS Bhopal. So she's a person who puts her knowledge to practice. I hand over the sessions to you, Dr. Purnima.
Thank you so much, ma'am, for kind words. And thank you so much. So,
Dr. Randhir is there now.
ma'am, let me
Yes.
see.
Yeah.
Yeah,
So
yeah.
Dr. Randhir, please, can you welcome the chairpersons for Dr. Sunita Tendulwadkar madam's talk, please? Dr. Randhir,
Yes.
you have to invite the
Okay.
chairperson.
Okay.
Yeah.
Sorry. So I invite Professor Dr. Madhuri Chandra ma'am. She's a very renowned obstetrician and gynecologist, and I think she's the only the person who got the national level Foxy. She was chairperson, and she's a true leader from Bhopal. So I welcome her, ma'am, and she has been a very good academic. I just tell in Hindi, anybody in Bhopal, Sunita ma'am, Ananta ma'am, gets problem in any complication, they will love to call Madhuri Chandra ma'am. So I welcome
Madhuri Chandra madam, Madhuri Chandra madam, I know for years and decades.
Yeah, ma'am. Therefore, I told. Yeah, so I welcome Madhuri ma'am, and next chairperson for this today's webinar. I request the next CEO. So Dr. Milind Shah sir, he's a senior most. He's my elder brother, and as you told Smita ma'am, he's also very senior and very humble, and he's more closer to us also because अब तो उनकी बेटी हमारे मध्य प्रदेश में आ गई है. She's
अरे बच्चा, वो मेरा बचपन का दोस्त है, हमने रेसिडेंसी साथ में की है. So I'm catching up everyone from you. मैं और मिलिंद ने रेसिडेंसी साथ में की है, so don't worry.
Exactly. Yeah, very close to. और सुनीता मैम, अब हम लोग मैडम एक मैरिज में, I went to one marriage there, classmates और the marriage classmate के son से और classmate के daughter से शादी हुई, टोटा गंभीर in Bhopal. So कितना अच्छा लगता है मैम. Yeah, so I welcome sir to you also, and I think you can we can continue going on. Milind sir.
Yeah, sure. Yeah. Thank you very much, Randhir, for this really very affectionate introduction.
Milind, please skip my introduction. Please skip this.
Yeah, okay, great. So friends,
let us start with our academics.
Yeah.
Let us start with academics.
Yeah. So indeed pleasure to be part of this perfection series season, and Sunita, I must congratulate you for this initiative and the support you have received from the entire group office bearers of ISAR, Nandita, Sujata, and all others. And what I can say about the Monica and Randhir, yes, they're always hardworking. Recently, we witnessed that during the ISAR conference at Bhopal, which was one of its own kind. And Purnima, yes, I also was knowing her since she was with Chaitanya, again a very close friend. And now I can see her enthusiasm in communicating with all of us to see that everything runs very smoothly. I'm also happy to see all, my very close friends, the Ashok, Chaitanya, as well as Dr. Sudha has not joined, but all of them, they were, meeting us since years. And we know that there are a lot of interaction of knowledge which can happen during this particular webinar. What I can say about the antenatal care, all said and done, actually it's still a needed thing in many parts of country. Recently, when I took over as a Saif Madhur Committee of Indian Medical Association at state level, I realized there are still pockets where we need to have a good antenatal care, whereby we can curtail a lot of morbidity when it comes to the maternal health, especially nowadays with more and more incidences of more increased incidences of or the cases of adhesive placenta. We realize that antenatal care can definitely make a major difference. whereby we can shift this particular women to a proper center, whereby they can get the good antenatal as well as the intranatal care to avoid the mortality or the morbidity. And that's why we are really eager to listen to you, Sunita, of this inverting this pyramid of antenatal care, because we always said that the emotional support is the last, actually, the pillar or the brick of this antenatal care. But I'm very sure that is going to definitely take a major role when we are getting good counselors also with us in all our clinics or the hospitals, where they teach actually the patient as well as the mothers as well as the family members and the husband about how actually we can give a good outcome, safe mother and safe baby. So with this, yes, I'm going to not give the formal introduction of Sunita, but as she told, yes, I know her before her marriage because we were in the same college and we really had a lot of fun in the Dr. Vaishambhan Medical College, where we used to have a lot of actually interaction as far as the various studies are concerned, various topics are concerned. And eventually when we became consultant or the various office bearers of various organizations, I realized a tremendous leadership in Sunita. And I can see her work in Ruby Hall as well as other centers. Definitely it's appreciable. I'm very sure, Sunita, you're going to go a long way after this particular year, because I know this another actually challenge you have taken and you are going to conquer that with good, actually, the flying colors. So I wish you all the best. And with this, I think I will request now Sunita to start with her very important topic, the inverting the pyramid of antenatal care.
Thank you, dear. Thank you, dear all. Thank you. Now, without wasting much time, let me start. We spoke with everyone, just Madhuri Chandra madam. चश्मा लगाने के पहले आप बहुत अलग दिख रही थी. I would not have recognized you on this because years together, I'm seeing Dr. Chandra madam the way she is. And on Tuesday, I'm looking forward to see everyone in Bhopal. We are arriving, ma'am, just to meet you all the way to the beautiful city of Lakes. So friends, let's go.
Yes.
Yes.
Welcome. And we are looking so forward to your topic, inverting the pyramid of antenatal care. I think that is the hot topic of the day.
And all the best, Dr. Sunita.
Oh, great.
All the best.
Thank you.
So,
Thank you.
Sudha also joined and Madhuri also joined now. Good.
Oh, we have everyone join. Sudha,
Yes.
madam, would you like to say a few words? And I'm so glad that you are here.
Yes,
People know about Sudha madam, but let me tell you, Sudha madam's daughter I met, and I am very impressed with her, Sudhaji. I am going to pull her. You may be in IFS, she will be in ISAR.
I know. It will be a happy moment. And I'm good morning.
And we will just have a fight in the house. Yes, good evening, good evening. So, friends, inverting the pyramid of antenatal care, if you see, I sometimes tell Dr. Pooja Lodha, you all know Pooja Lodha, who had done residency under me between 2008 to 2011. And I used to tell Dr. Pooja, we do preventive obstetrics. What do you mean by preventive obstetrics is what complication this lady can have in third trimester. Start thinking not only during the first trimester, but preconceptionally also. And then we used to take care about how to prevent. Unfortunately, we were not intelligent enough to publish the preventive obstetric word, and Nicholas and team has done this beautiful job in 2011, calling it as inverting the pyramid of antenatal care. So we know all fetus is like a Pandora box. And today I'll be covering my topic with 12 weeks, the window of opportunity. What is the rationale about this 12 weeks window and how we can help many patients with that. Now, if you see before, the first trimester was completely overlooked. It was just the 16 weeks or 24, 28 weeks. These were the multiple visits because after that we need to call the patient every 2 weekly or maybe a weekly. They were irrational visit, just patient coming and checking weight and blood pressure, where the 16 weeks pregnancy till was overlooked. Now, what has happened in evolution is the 12 weeks has been taken it very, very seriously. And also every visit has a predefined what is the purpose of this visit. There is a predefined subject. Patient knows why she is coming today to the antenatal care. So most fetal anomalies and the structural anomalies can be diagnosed by the end of first trimester. Cell-free DNA, which has become a most advanced thing in screening for the fetal aneuploidy, and a non-invasive way of it, just taking the maternal blood and collecting the cell-free DNA has become an easy option, though little expensive option, I should say. The risk of some pregnancy complication that become clinically evident only later in pregnancy may be established in the first trimester. The incidence of this disorder, for example, preeclampsia, my patient at 12 weeks only, if I tell her with her low PAPA or high PI index, history of IVF conception, elderly, and on the top of that, multiple pregnancy, PCOS conception, I will tell the patient, look, you have very high chance. Not only it is the starting of the ecosprin or the blood thinner, but I think one thing I do differently is I control their weight. If she is already 70 kg, maybe in throughout the pregnancy, I will allow her just 2 kgs or 3 kgs. So 200 to 300 gram weight gain. So this all will help us to ensure that she doesn't develop the preeclampsia, and to her mother-in-law or the mother, we have to draw a diagram with the maternal weight and decrease in the fetal weight. So inverted pyramid diagram, which is so much important. Also, first trimester screening also helps us, which are the patients who can go into FGR, not only because of the preeclampsia, but other problems. So maybe placental issues, and we can able to help them, or the patients who can go in a preterm. So instead of multiple irrational visit, we are trying to get early estimation of risk stratifications, shift of antenatal care from a series of a routine to individualize, and with the predefined objective why you are coming today. So I feel this 12 weeks, it's not only just the NT-NB scan, but it is beyond. There are bigger problems, and looking beyond the aneuploid is very important. We peep into the stolen future of the baby, where NICU admission, neonatal morbidities and mortalities we can avoid than just working on the chromosomal pattern of these women. So we call these 12 weeks as a one-stop assessment for a risk. Now, what do you mean by one-stop? What are the various things I would like to see in this is, first is accurate dating with your CRL, anomaly scan, risk stratification for preeclampsia and FGR. You should know that there are apps available. You put it all and you may get ready-made. These apps are free. I'm going to show you one of the site also. Preterm birth screening, chorionicity best established during this. So our aim of 12 weeks inversion has started becoming, first, let's talk about fetal aneuploidy. 11 to 14 weeks screening for the fetal aneuploidy. Now, people usually say, okay, about the 35 age group, I would like to screen more. I would like to remind you, the women who are planning the pregnancy, the number of women below 35 is more than after the age of 35. So age is not the criteria to whom, because then the population index below 35 is more. The CRL, I need to thank Dr. Pooja Lodha for providing me not only the photograph, but the video also. And CRL, the best way how, I think we need to appreciate our radiologist, sonologist, fetal medicine consultant to get that fetus perfectly in that position. Sometimes with some patient, they really struggle a lot entire day. So what we do, apart from the maternal detailed history, which is very important, any subject, history detail about the age of the patient. You know what, even if it is an IVF conception, you should know that if the IVF conception has happened with the donor eggs, the chances of PIH is more than with the self eggs. Several studies have proven. So detailed history, even if it is an IVF conception, also history, whether it is what was the indication for a IVF, then the double marker blood test we do, and then these bars are coming so much in my way everywhere. So I hope these are not seen to you people. So we just do all these markers. Now, there are software which goes in the sonography machine of the sonologist, which they convert into the MOMS, free beta HCG and PAPI. And apart from the age, apart from the ethnic group, they just work out on not only NT-NB, but they also see the ductus venosus, tricuspid wall, Dopplers, and they establish what, as an obstetrician, I can see is only the last page where she writes background risk and adjusted risk. Though I tell my fellow they are supposed to read everything. If they read at 30 age group, if they ask in the exam at 30 age group, what is the background risk of trisomy? If they have read this 100 times in their post-graduation, they will not forget at least 1 in 500, 1 in 1,400 and 1,400, 1 in 4,000 about trisomy 13. And what is the adjusted risk about these? It becomes easy for us. I think when we were studying or early part of our practice, such sophistication was really not there, which has developed in last 2 decades, I should say more. So combined risk stratification, suppose if they give me and she gives me a high risk, obviously I will go for chorionic villus sampling. If she tells me intermediate, if the patient is affording and if get explained and understood, then NIPT, which helps us to make our life also more simpler, or the early anomaly then do at 16, 17 weeks. And if any more than 2 risk factors, they still should go for amniocentesis, and low risk continue the routine care. And if it is low risk, less than 1,000, you don't have to do at 19 weeks. I think the government has liberated us to do the MTP at 24 weeks, has helped us a lot to delay the amniocentesis. Otherwise, before we used to do amniocentesis at any cost at 16, 17 weeks, only because by the time the report of genetics comes and we have to abort, we have a deadline of 20 weeks. Apart from that, fetal abnormalities. This is a very interesting chart. The dark purple indicates period of fetal development when major defects in the bodily structure can occur. And the pink one is the period of development when major functional defects and minor structural defect. So if you see the central nervous system by 16 weeks, everything is done. The heart actually formation, the arms, legs, the eyes, all can happen by 6-7 weeks. Though the heart can be best seen at 20 to 24 weeks, the structural formation, major defect, if at all has to happen, they will be so early. External genitalia, the ears, the arm, the legs, the eyes, everything. So before 12 weeks of pregnancy, you can see majority of the structural formation has happened. So these are the various anomaly scan, and these are probably, I don't think I can read the slide. This is so crowded, but there are always detectable, potentially detectable, and probably undetectable structural anomalies they can. So again, that's what I said, thanks to Pooja. Midline choroid plexus examination, then they go from cranial to caudal direction, and then they will go down, and then the orbits are beautifully seen. They will go further down and they will get to see the upper lip. So you can see they can diagnose all these structural anomalies if seen carefully. Then comes the heart and the lungs. Then they will go down further, and then they will reach to the diaphragm and the stomach bubble. From there, they can go to the bladder, and they can see that before the bladder, the cord insertion, and then they will go down further to see the bladder. And then they will go on the lateral view where they can see all the extremities little better. And also the spine of the baby can be seen so beautifully. So I think probably they count even the fingers and the knuckles so well now, with the advancement in the technology. That's why I said the technology advancement we should use to the benefit of the health of a woman and also this neonate. I'm sure how I feel in endoscopy, we started with single chip and now we do with 3D and robotics. I feel retrospectively how I was used to do in single chip, I don't even know. The tissue differentiation was so poor. I'm sure Dr. Khurana must be seeing what he has started 40 years ago and what technology is giving him the upper hand. He must be wondering how I used to work with that small tiny machine, which was the black and white. So we are now in simplifying the first trimester diagnosis of this banana sign and the lemon sign, which we used to see in second trimester, now have been replaced. Now, why this is early need for in a open neural tube defect, especially in India, because it has a huge burden of these folic acid deficiency, low socioeconomic status, consanguineous marriages, advanced maternal age sometimes. So it's very important that we diagnose this. And this is what the echogenic tip nose, nasal bone, the brainstem, intracranial translucency, and nuchal translucency. If they get this picture and they send us, that's a beautiful thing. The normal brain and the spina bifida, I think they now very efficiently, they can diagnose it. Look at the spina bifida. I think even if I'm not the sonologist, I don't do obstetric sonography. I don't think if I get the picture like that, I will miss the spina bifida. So I think these are all very important about the fetal aneuploidies and structural anomaly. Now, what about the small for gestational age and preeclampsia? Can I diagnose that? Can I take a preventive method? Can I help those women who are going in a FGR? How can we do? Of course, as I said before, also maternal history, mean arterial pressure, and then you see the uterine Dopplers. Now, what happens is the early risk stratification. If the age of the patient, her BMI, pre-existing hypertension, diabetes, or assisted conception, and if the biophysical parameters of uterine artery pulsatility more than 2.5 at 12 weeks, more than 1.5 at 20 weeks, it's all along. I don't do in my patients routinely the inhibin levels or other levels. I do only beta HCG and PAPE study. And if she has a low PAPE, she has a high pulsatility index, I always remain very, very careful. We all know that if you start the ecosprin at early age, as early as before 16 weeks of pregnancy, then only it will help you in prevention. Now, apart from that, if it is an immunological positive patient, which adds the fuel in a fire, I may add on low molecular weight heparin to the patient if I see all these. So implications of early detection, it directs such patient to specialty clinic. If you are from a smaller town, probably you have a crowd of 200 deliveries per month. You may not be able to see these high-risk pregnancies because they not only need a close surveillance, but more frequent visits. Availability of the specialist of fetal medicine or sonologist who will check these all parameters on a regular interval is a mandatory. Otherwise, send them to nearby. Now, even your taluka places will have a very good team who can help them. I have already spoken about the aspirin, and there is a robust evidence that you can, up to a certain extent, decrease the incidence of preeclampsia happening by becoming alert. You have a sensitivity index of this screening to 90% before 34 weeks and false positive rate only in 5%, while FGR around 75%, only 10%. And I feel it's okay. You were cautious and she did not had these unnecessary, you were cautious. It's okay. You have taken an extra effort, no matter, no problem. But if you have not taken, the consequences sometimes can be losing the baby. And these are the various software on this site. You can go and you will get those calculators. What about prediction of preterm delivery? I don't know, in entire OBGYN, only the incompetent os or os tightening is so badly debated, asking, is it evidence-based? I have seen with the low AMH as low as 0.6, 0.7, people are doing, still wasting their time with oral ovulation and asking them to have a time relation. Where does the evidence go during that time? I have seen with 1 million sperm count, patient is given IUI over IUI for 2 to 3 years till the biological clock of that lady passes off. That time, no one think about the evidence-based medicine. But when it comes to incompetent os, everyone is open to say, even for a twin pregnancy, IVF conceived, everything is normal at the age of 40. If I have the twins with everything normal, I will feel lucky. What can happen? Preterm labor can happen. Is there any way why this will happen? Because probably the cervix may not be competent to hold the 2 babies. Why I can't think of putting the os tightening or a cervical stitch for her? Why only I debate the entire OBGYN, entire Foxy debate on just cervical incompetence? I have seen the youngest guy or the smallest person from smallest region to the metro city, everyone debating only whether to put a stitch or not. I sometimes feel cervical stitch is so simple method to prevent the preterm labor or early abortions in second trimester. But we debate. Indians are masters in putting a cervical stitch. While the white skin, the European people are not masters because their guidelines don't allow them to practice unless they have 3 losses. But in those patients, for them, prediction of preterm delivery comes very much important. And how do we do? How do we do is only by doing the serial measurement on a sonography, not only of the cervical length, but also to see the funneling of internal os. Sometimes the cervical length may be 2.8 centimeter. Now you will say evidence doesn't allow me below 12.5. You will wait and watch. But internal os is showing the sign of funneling. Please consider it. I humbly request everyone today on this open platform, I want to say that only for these high-risk pregnancy who conceived with difficulty, very elderly age group where 12-week scan is showing no aneuploidy for the baby. And if you are finding 2.7 centimeter little funneling, please put up a stitch. Don't wait. I'm very sure if this would have been your sister, your daughter, or your daughter-in-law, you would not have taken a risk. You would have put her the stitch. And if you feel you don't want, please put them on at least the progesterones. The progesterones, this is the risk assessment calculation. That evidence has enough said that vaginal progesterone, and nowadays we have a oral capsule also, which is specially designed for preterm labor. I don't know what is there so different in that capsule or the strength, but these cervical pessaries, or just a minute. Yeah, Lakshmi, I'm going to join at 5 o'clock sharp. I will be. Thank you. Thank you. Vaginal progesterone, cervical stitch and all is going to be equally effective. No harm in putting. For a first trimester, for no reason, the patients are on hundreds of patients on the progesterone for a luteal phase support without evidence. So anytime you feel that there can be a chance of incompetent or the twin pregnancy, please put them on the progesterone. Prediction of complications of the teen. I always tell my patient, don't dance if you got a twin. More your teen incidence, more poorer it is your IVF results. You are giving twin pregnancy, indicating that you are loading too many embryos inside. All the complications are higher with dichorionic as well as monochorionic, but among the two, ART pregnancies, dichorionic is still little better than with the monochorionic. Of course, I can't cover twin pregnancy in this, but believe me, think about this. This is also, Pooja has prepared a slide where she says, 2 kitchen, 2 homes, everyone is happy. 1 kitchen, 1 house, everyone is unhappy. That's how she tells me to explain to everyone. And there are risk calculators even for the preterm. So friends, inverted pyramid of ANC is a better model. I think we should start in India talking about preconceptional counseling than 12 weeks counseling. Preconceptional, we work, we give them folic acid, we ensure that their diabetes, blood pressure, weight, everything, because sometimes it is the obesity which can cause missed abortion, aneuploidies, cardiac and neural problems. Early prediction modules are very good. It guides us about the frequency of monitoring and we need to refer the patient for a tertiary center.
And there's your beautiful baby. Any day now. Really? You're eating Doritos? He's eating Doritos on my ultrasound. Do you see what I have to do? I know. That.
So I just want to say one thing. Listen, the husband sometimes knows how to play with the baby while mother forget even to talk with the baby. Baby understands. Tell your every patient with the high-risk pregnancy, send positive vibrations to your baby. It is the mother who can protect the baby and help the baby to come out. And friends, no job is finished unless the paperwork is done. Ensure that your paperwork, you are safe, and fetal journey is a roller coaster ride. It is our endeavor to ensure that the fetus comes out smiling, unharmed. I humbly appeal all of you to bless me in this forthcoming Foxy elections. Thank you so much for your patient hearing.
Yes, thank
Congratulations.
you.
Wonderful talk. Wonderful. You have explained so beautifully
Yes.
the problems related with early pregnancy. It's very important one to know for each gynecologist and obstetrician who are conducting deliveries. It's wonderful.
Yeah.
All the best, Dr. Sunita.
Yeah, thank you. Thank you very much, Sunita. It was really a very, very lucid talk. And you know, it is really important to cover all those aspects which are in the 9 months you covered in 30 minutes so wonderfully. So I'm very sure that all the viewers, especially the youngsters who are there, who are listening to this, are going to get benefited a lot while they will deal with the parturient actually women. And Madhuri, I'm so happy that you are joined. So do you want to have some comments?
Sudha, can I ask you one thing? You are 40-year lady, twin pregnancy. NIPT was normal because now we do the twin NIPT even in twins. Cervix is 2.7 centimeter at 13 weeks of pregnancy. Will you wait and watch, or you will say, this is my IVF conception, 40 years to get euploid embryo, to get her implantation, to get her success is difficult. I got the success. Let me work hard to reach out this pregnancy to 36 weeks at least.
Oh, definitely. And it requires, she's 40 and twin pregnancy, definitely the cervix should be tightened and she should be in follow-up with a very careful monitoring. And I will like to know that any other abnormalities are there or not. Patients should be followed properly with the fetal medicine people, the sonologist, and they should give the very right picture that the patient is so happy for at 40 and suddenly some abnormality comes, then it becomes a big problem. So it is very easy. Of course, up to 24 weeks, government has allowed to do the MTP, but she should not fall in that group actually.
You know, only for incompetent os we debate so much in India. I have no idea why. AMH of 138-year, for months together, we keep on doing ovulation induction. I humbly appeal all, we need to do evidence-based practice, but we also need to do emotional based practice as well.
I have seen patient with 0.01 AMH, people are trying timed intercourse. I have seen it.
And that when we don't talk about evidence-based medicine.
Yes. And when they come to us, suddenly we said, oh my God, you don't have the egg and you have to take donor. They start perspiring.
It is Sudha ma'am and Sunita ma'am, it is a patient. They force that, हमारे बचे हुए अंडो निकालो निकालो, try to get my bone.
Yeah. एकदम किसी ने बताया नहीं अभी तक. अरे आप पहले बनो बता रहे हो कि अंडे खत्म हो गए. They start wondering कि are you okay or not with us? That is the big problem.
No, Sudha ma'am, ask the patients are Google. They want that out of 10 people, if all the 10 are saying no, then they will go. They are always search for 11th who is in their favor.
Very rightly said. Very rightly. Yes. Wonderful.
Anyway, thank you so much for giving an opportunity. Randhir and Monica, you are helping me so beautifully. Thank you. Thank you for collecting the diamonds on one platform here.
Yeah, we always
And you are the Kohinoor.
Yeah.
No. I'm a small girl, yeah. I'm a small girl in front of these all legends.
And you are the Kohinoor who's still in India. We will not let that Kohinoor go to UK.
Sunita ma'am, the youngest Prime Minister of whole world is New Zealand. She was just, I think, 29 or 31 years. So madam, you will be always young. Don't worry. Our president,
you know, Narendra Malhotra is the youngest Foxy president of India. At the age of 48, in 2008, he had become the youngest president of Foxy president.
So ma'am, you are unopposed and we are just respecting ki our cake is ready.
Let's move on with the academics, Randhir. Let's move on with academics.
You will win. You will. Even if it is not unopposed, there is no comparison, Sunita. You will get through.
Thank you, ma'am. Thank you. Blessings are important.
Thank you so much, Sunita ma'am, for that brilliant talk. And you never cease to amaze us. You have that perfect knowledge of ultrasound also. You are talking about tricuspid regurgitation. You are talking about DV. You are talking about me.
My Pooja makes me do everything. Pooja Lodha, I have a golden girl with me. She makes me do everything.
So,
and important one is Purnima also. I am in UK, but she has called me, ma'am, are you going to join?
Okay, ma'am, you are in UK.
I am with my daughter, the elder daughter.
Okay,
Cambridge. She's in Cambridge, so I'm sitting here.
So, madam, 11 o'clock hoga. There's morning there. Before noon.
Yeah. That's why it is 12:30. That's what I said. Ki good morning and good evening to all of you.
Sorry to disturb you, ma'am, but we all wanted to see you.
So nice of you. So nice. Beautiful.
So after this brilliant talk by Sunita madam, let us move on to the second session. Purnima, can you proceed, please?
Yes, ma'am.
Yeah.
So for our next session, for chairing our next session.
Oh, we have a Sushma also. Lovely Sushma. Congratulations for becoming a president of Nagpur Society.
Congratulations, Sushma ma'am. Has she joined, Dr. Purnima?
I can't see her name, ma'am.
I'll call her. You continue.
Yes. So for chairing our next session, I would like to invite Dr. Sushma Deshmukh ma'am on this platform. Ma'am is the director of Central India Test Tube Baby Center and HOD of Obs-Gynae Department, Getwell Multi-Speciality Hospital and Research Center. Ma'am is chapter secretary Vidarbh IFS 21 to 24. And she is also very dynamic president of NOGS 23 to 24. Ma'am has organized 2 national and 1 international hysteroscopy carnival. And she is regular faculty for Global Hysteroscopy Congress in Barcelona since 2017. Ma'am has written more than 25 academic and non-academic books and conducting public awareness programs for adolescent, reproductive, and menopausal group. I welcome you, ma'am. I hope ma'am comes and join us soon. Next slide, please. So our next chairperson is Dr. Juhi Agrawal, ma'am. Ma'am is professor in Department of Obstetrics and Gynecology, Gandhi Medical College, Bhopal, and has published various national and international journals, papers in journals. Ma'am is faculty at various AICOG conferences, and she is a straight trainer for CAC and STI. Ma'am is secretary of Bhopal Obs and Gynae Society for consecutive 2 years, and she is a co-investigator in project by ICMR. Ma'am has awarded many presentations in West Zone in 2012. Awarded topic is PPIUCT. Second prize in West Zone Yuva Foxy. Award second prize in post representation and second prize on post representation in IMS Indore. So I welcome you, Juhi Agrawal, ma'am.
Thank you, Purnima, for the kind introduction. Thank you so much.
Welcome, Dr. Juhi, and it's lovely to have you here. Dr. Sunita ma'am, she was a past secretary, very dynamic secretary of Bhopal Obs-Gynae Society.
Thank you so much, Dee.
So,
Ma'am has been there once.
yes, and Dr. Sunita ma'am is again visiting Bhopal on Tuesday. She will be amongst us on 30th of May for a CME and dinner meeting in the evening.
In the Marriott, at the Marriott. So,
At
yeah, in the
Marriott.
Marriott.
So we will be circulating. In the morning, we will be visiting Sagar, and the evening it will be Bhopal.
Sure, we'll see you, ma'am. We hope to see you.
Yes, yes. So, and Dr. Sushma is also joining. I think, has she joined? No, she's joining. So we can introduce our third chairperson.
Yes, so I welcome you, Dr. Malti Bhojwani, ma'am. Ma'am is assistant professor of Obs and Gynae Department in Jaipur Medical College, was assistant professor in 1980 and worked for 7 years. Ma'am has worked as consultant in biggest hospital of Saudi Arab, Riyadh, Central Hospital for Women for 1 year. At present, ma'am is director of Malti Hospital in Test Tube Baby Center Bhopal, which is advanced healthcare institute having world-class facilities. Ma'am was past president of Obs and Gynae Society Bhopal in year 2007 to 8 and promoted social activities like Beti Bachao and Beti Padhao Abhiyan and has held many health camps and educational seminars as well. Ma'am has participated in many conferences, TV programs, mass education program like schools and ladies clubs, published the articles in the newspaper and journal. And I want to mention that ma'am is running Malti Bhojwani Foundation, an NGO as well, since 2021. And this NGO is dedicated to relief of poor people, education, medical relief, preservation of environment, including watersheds, forest, wildlife, and advancement of any other objects of general public utility. So I sincerely appreciate, ma'am, of your hard work and sincerity and your contribution towards society. I welcome you, ma'am. Thank you so much for joining.
Thank you, Purnima. Thanks for the kind words.
So over to you, ma'am, for introduction.
Now I welcome. Can you will please? Good evening, all, and I am thankful to the Perfection series to give me this opportunity to chair this session. And hereupon I invite Dr. Girish Patel, who is at the moment Secretary of Gujarat chapter of Society of Fetal Medicine. He is from Gujarat, and also I am also from Gujarat. He has graduated and done his post-graduation from BJ Medical College, Ahmedabad in 1993. And he is at present attached to the Wings Hospital, Ahmedabad. As an obstetrician, he has conducted a mega number of deliveries, that is 12,000 normal deliveries and 6,000 cesarean sections. He has got special interest in fetal medicine, and he has presented first paper in Washington FICO 2000 on the transperineal sonography, which is quite unusual in diagnosis of placenta previa. He is also doing neonatal echo and adult echo And he has conducted many workshops, delivered many presentations, and attended more than 250 CME. And hereupon, he is going to give a talk on, I think, first trimester scan in post-ART pregnancies, which are very, very precious pregnancies. And hereupon, I call and I welcome Dr. Girish Patel for his deliberations on this interesting topic. Thank you.
Is my screen clearly visible there?
Dr. Sushma Deshmukh ma'am has joined us. So I
Make it
welcome
full
you.
screen. Make it full screen.
Ma'am, are you there?
I think I can see Dr. Sushma Deshmukh's name, and we welcome Dr. Sushma Deshmukh from Nagpur, President, Nagpur Obs-Gynae Society, to join us as chairperson of the second session of this webinar, talk by Dr. Girish Patel, sir.
Should I proceed, ma'am?
Yes, 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 please.
Good evening.
Yeah.
Thank you. Thank you for the kind words, Malti ma'am. At the outset, I really bring greetings from Gujarat chapter of Society of Fetal Medicine. We need blessings from our SFM mentor, Dr. Khurana sir, and invited guest, Dr. Nagori, Dr. Sunita ma'am, Dr. Monica ma'am, her whole team, our chairpersons, all the dignitaries, and our participants. What I'm going to apprise you, probably Dr. Sunita ma'am has made my task quite easier, no? By compiling everything in her talk, that inverted pyramid. What I'm going to narrate in front of you is first trimester scan in post-ART pregnancy. Now, going little in detail, that when a woman with conception enters your consulting room, she has a risk that her fetus may have chromosomal defect. So any woman enters to your consulting room with two things written on her forehead. What are those two things? One, maternal age, and second is gestational age. So when you two things in your hand, you have some background risks. Dr. Sunita ma'am has told us a 30-year-old woman, 12 weeks, 1 in 500. So that becomes your a priori risk or background risk. Now you are carrying out ultrasonography so that you are getting some markers. Now, the most powerful marker is the nuchal translucency. And along with that, you have some other optional markers also, which may not be visible with everyone, but nasal bone, ductus venosus, and tricuspid regurgitation. Now, when you have this a priori risk combined with this marker with different likelihood ratio, which depend, of course, on the result of our screening ultrasound scan, you get a different risk, and that is your adjusted risk. So now what is the most popular new effective screening method? The time has gone when before 20-25 years, women above 35, they were subjected to amniocentesis, and there were less detection of the trisomy babies with more abortion rate. Now this program leads to invasive test requirement from 20% to less than 3%. So what is that screening program which is in vogue, which is popular? So you have ultrasound scan and serum biochemistry, namely beta-HCG and PEPE. Now, I should also tell that apart from this first trimester scan for aneuploidy only, there are other advantages which Dr. Sunita ma'am has already told us. Accurate dating of the pregnancy, which is not there actually an advantage in post-ART pregnancy, because in ART pregnancy, date is already known. Second, you can diagnose, not suspect, diagnose major fetal abnormalities like anencephaly, holoprosencephaly, ectopia cordis, limb body wall, body stalk anomaly, and so many, and then you can take some decision. If it is a multiple gestation, first trimester scan is a good window for chorionicity determination. And of course, you can identify the women who are at risk of developing preeclampsia. So you have maternal age, ultrasound nuchal translucency, fetal heart rate, serum biochemistry, and new ultrasound markers, which I have already told you, nasal bone, ductus venosus, and tricuspid regurgitation. Now let me talk to you in detail about nuchal translucency. Now what is nuchal translucency? It is the sonographic appearance of a collection of fluid beneath the neck here. There you have some fluid-filled space behind the fetal neck. Every baby has. So that is your nuchal translucency. If it is increased and goes above 95th centile, then it becomes significant. Now, irrespective of whether it is septated or not, it has got same importance. Now, the incidence of chromosomal and other abnormalities, remember, they are related to the size of nuchal translucency rather than its appearance. So this is a trisomy mouse, actually. This is a trisomy 16 mouse. This is our baby. Yes. Now, you have a question that suppose nuchal translucency is raised. Why you carry out the scan between 11 to 14 weeks only? Between 11 to 14 weeks, whosoever baby has increased raised nuchal translucency, even in trisomy 21 babies also, generally it resolves. Why it resolves? Because the delayed lymphatic, veno-lymphatic connection, which occurs in trisomy babies, connection now happens. So after 14 weeks, trisomy babies and normal babies, their neck region resemble the similar appearance. So nuchal second trimester usually resolved. Now in few cases, if it persists, then the word nuchal translucency is not used. Then you have to tell nuchal fold. So same nuchal becomes your nuchal fold. Now what you have to, if it persists like a nuchal fold, the cutoff value is 6 millimeter. If it persists more than 6 millimeter, what you have to do, I'm going to narrate afterwards. So the nuchal translucency and fetal heart was actually an old adage. In 1987, Barna Seraph, who recently actually died, she associated trisomy 21 babies with an increased nuchal fold. Afterwards, in 92, Kipros and workers, they associated aneuploidy with similar thing, but between 11 to 14 weeks, what you call nuchal translucency. Now remember, nuchal translucency is not only a phenotypic marker for aneuploidy. It is associated with variety of conditions, heterogeneous group of conditions. There may not be a single underlying mechanisms. There are skeletal dysplasias, diaphragmatic hernias, certain metabolic disorders. So many things are there where you may have raised nuchal translucency. Now, what is the optimal age? 11 to 13 weeks, 6 days, what you popularly call 11 to 14 weeks, or between crown rump length 45 to 84. Why not before 45 CRL? Because there are no normograms available. And before 11 weeks also, if you do something in raised nuchal translucency, if you do invasive, then needling will cause some placental ischemia, and it will lead to transverse limb reduction defects. And major abnormalities can be diagnosed between 11 to 14 weeks. That is after 11 weeks. So that's why 11 to 14 weeks is a good window for this screening program, which was there. And now people are using the same window for many anatomical defects and preeclampsia risk. Another point why you have to have between 11 to 14 weeks, because affected women, they can choose the option of first trimester termination and less social embarrassment. Chromosomally abnormal feti, they show tendency to have decreased abnormal accumulation of nuchal fluid afterwards. And also after 14 weeks, fetus becomes vertical. So you will not be able to get an appropriate image. So that's an appropriate image. Now, two things are very important. First, you have to get an optimal image for CRL. Now, if you ask me, out of CRL image and NT image, CRL image is sometimes more difficult. But when you get an appropriate image of CRL, that what are the criteria? You have to have good magnification till almost fetus feels 2/3 to 3/4 of a screen, mid-sagittal section, that the profile, spine, rump, crown, everything is visible. There should be a neutral position, and that's why there should be a fluid pocket between the chin and chest. Fetus is transverse, crown and rump is clearly seen, crown is also clearly seen. And once you get this image for CRL measurement, you put correct calipers. So you will get optimal CRL for that gestational age. If you have good CRL image, what you can do, just put a box, cut head and upper thorax, and you will get an NT image. This is a very old image when we were using our Voluson 730 expert machine. So head and upper thorax are visible. Now you have fantastic machine. Now see the difference between this image and this image. This is our Voluson E10 machine. So this image, if you can get in any baby, that's a really optimal image according to Fetal Medicine Foundation criteria. Now what this image tells us, head and upper thorax are visible. That's a neutral position. That's the tip of the nose. Upper line is the skin overlying the nose. This is the nasal bone. You have a palate. You can see the diencephalon, which is a mid-side section. Then this is a brainstem. This is your typical intracranial translucency, which is a new marker for your neural tube defects. That's choroid plexus of the fourth ventricle. This is your future cisterna magna. This is your occipital bone. And that's the skin behind the occipital bone. And when you measure the NT, you should measure this. And this is your amnion. So if you can produce this image, it would be a really good image according to FMF, which you should try to go as near to as possible. These are the different images with different machines. Now, everyone doesn't have that good quality machines. So in hospital, suppose if you are doing any program for screening for aneuploidy. Now, Dr. Aparna is going to tell us how you can develop robust program for screening of aneuploidy. For any robust program for screening of anything, you should have our understanding robust. And then you have a good concepts and counseling, because screening for aneuploidy, rather than performing ultrasound, you have to explain everything to our patients who are sometimes not able to understand fully. So you have to make them understand that what is this program. So pre-test counseling is must, then you carry out ultrasound, and then post-test counseling, because the screening for any program is 1 + 1 is not equal to 2. So you are sometimes in the gray zone that patient must understand. Now, how will you measure the nuchal translucency? Now, when you get this image at the back of the neck, you have to measure inner to inner, you gain down, measure more than once, and consider the maximum one. Automated measurement tools nowadays are available. Not automated, I would say, it's a semi-automated. Why semi-automated? Because you have to put a box by yourself. And then after putting a box, whatever anechoic space is there, machine automatically measures. And the advantage of this semi-automated tool is a reproducibility. Now, suppose if you have umbilical cord around the neck, then you have to measure one above and one below and average out two, so you will get the ending. Now, this is one more image of nuchal translucency. You have seen that the classic textbook style of image, but your all images, even if you audit by yourselves, may not be but you try to reach as near to as possible. Now, let us see one case. You can see the tip of the nose. That's a 12 weeks, 5 days baby. That's a palate. You have only, that's a 3-line appearance is absent, and see at the back of the neck. The nuchal translucency measurement is 4.6. So it is more than 3.5. 3.5 or above always falls for any gestational age more than 99 centile. And there is no question of the NIPS or serum biochemistry. You must carry out invasive when nuchal translucency is above 3.5. We carried out Corion-Villus sampling, and that baby was trisomy 21. Now look at this. Another move. Yes. So when you are doing this examination, I will show you movie. So when you are carrying out this examination, when fetus jumps, you take an advantage so that you will get nuchal membrane visible, amnion also visible. So you will get a clear-cut idea where actually nuchal lies. So then let the fetus settle, and then you can choose the optimum frame out of that whole cine loop, cut into the head and upper thorax, and produce an image for nuchal translucency. Look at the whole video clip. So that's a tip.
Girish bhai, in
Image
last,
is not visible. Image
last
is
slide
not
video is
visible.
not seen.
Yeah.
Last
Video-
slide.
Yeah, you can replay, Dr. Girish.
Okay.
Last one.
This is now visible?
No.
It is not visible.
Till now,
No.
the PPT was moving very smoothly. Just in last slide, we are not able to see video.
Wait, my dear.
And sir, we would like to see these videos. They are so wonderful.
Yes. Now, can you see now video?
Yeah, now it is visible.
Okay, ma'am. So now see, once fetus jumps, you take an advantage, as I have told you. That's the tip of the nose, skin overlying the nose. That's a nasal bone. Now, one thing is very important. Nasal bone echo density is always more than the echo density of the skin overlying the nose. So when this line is more dense than the upper line, you can say nasal bone is present. When unilateral nasal bone is absent, this line will not be more dense than the skin line. So in this image, that's a palate. This is the whole image I am telling you that what you can study. Nuchal translucency image is not only for nuchal, it is for nasal bone, palate, intracranial translucency, see, which I have already marked here. So dancephalon, brainstem, intracranial translucency, cisterna magna, occipital bone, and you have nuchal at the back. Now, what is the technique? What is the technique for nuchal translucency? So once you produce this image, that's a calvarium, you have a fox, and you have a choroid plexus. Once you have this image in your hand, just rotate your probe at a right angle. Once you rotate your probe at a right angle, you will get an anti-image. See what I am doing. Keeping the fox, which is a midline structure, I will keep in my view and gradually, see here also, this is your brainstem, intracranial translucency, cisterna magna, and this is occipital bone. Here also this three-line appearance is quite visible. And then you rotate your transducer gradually so that you will get classic picture of nuchal translucency image. Now, let me talk to you regarding the nuchal translucency, whether it is always present in trisomy babies. No. 75 to 80% of nuchal translucency thickness, which is above 95th centile in trisomy baby, it is not present in every baby. This is a phenotypic marker. So those babies where raised nuchal translucency as a phenotypic marker is not present, you will miss that baby. So trisomy 21 feti, another thing which you remember, shows no relationship between the nuchal thickness and maternal age. When trisomy baby is there, whether the woman is of 25 years old or 38 years old, nuchal thickness remains same. Now, Dr. Sunita ma'am has already told, and Dr. Khurana in her introduction guest talk has already told that even your woman is of low risk, 1 in 6,000 say. Your after ultrasound scan and serum biochemistry, it is 1 in 6,000. As a pre-test counseling, always offer, this is a cafeteria approach, because nowadays NIPS is very cheap, 6, 7, 8,000 maximum. So that's a better screening tool than our ultrasound plus serum biochemistry, namely PAPE and beta HCG. That can detect little more. If you do very optimal scan, ultrasound plus serum biochemistry, if you go near to 90%, NIPS gives more than 99%. So you must talk regarding this tool. Nowadays, affordability of our patient, precious pregnancy has increased. So in our hospital, 90% of the patients, they are opting for NIPS. And along with NIPS, you can have placental function assessment by PAPE. Now let me come to the other marker, nasal bone. Now, what is that? The nasal bone, when you write in your software, there are 3 options, whether nasal bone is present or absent. When you are in dilemma, third option is also there that you cannot examine. Because in each and every patient, by each and every sonographer, depending on your skill, nasal bone remains a little bit dilemma forever. Now, forget about the normograms. Nowadays, they are available for first trimester also. But present or absence, that is also a very good tool for putting into the software that accurate assessment can occur. Let us see the movie. So when you have that CRL image, yes. Now zoom the image, tip of the nose, skin overlying the nose, and that's a nasal bone. Once you get this, here, see, there is no bone. No bone means frontal process of maxilla is absent. So when I see this, actually there are here 2 nasal bones. Now go gradually. I will rotate my probe and bring coronal section in front of you. So when you see coronal section, that means face towards you, you will see here there are 2 bones. And then, can you see 2 bones? Now we come to the coronal section. In coronal section, definitely that's a twin pregnancy. Another baby is also there. See, now you can see 2 clear-cut nasal bones. If 1 bone is absent, in your mid-sage view, line will not be so echodense of that nasal bone. So nasal bone should be evaluated carefully. If you are very confident, write present. If with raised nuchal translucency, if you find really absent, write absent. When you are in dilemma, choose the option third one, cannot examine. Don't write absent, because what happens, once you write absent, your risk increases and patient wanders from this door to another door. So that's another. That's also a twin pregnancy. This is 1 baby. Another baby where I have an optimal position for CRL, and immediately I will choose to cut head and upper thorax out of that CRL image to get a image for nuchal translucency. So you have skin overlying the nose, nasal bone, tip of the nose, like that. See the whole movie. So what I told you, you go like this, fox cerebri, choroid plexus, and there from rotate your probe gradually so that you will get a copy textbook style of figure. And once you are in the exactly midline, you will see the bladder, urinary bladder is visible. If it is little field and you have no hands visible. So CRL image sometimes difficult even than the NT image. Now look at, after nasal bone, we would love to examine the ductus venosus. Now this is also a twin pregnancy, because nowadays I am working in an IVF clinic where we have 30-40% multifetal gestation. Now look at this baby. I will examine the ductus venosus. So according to FMF, I will just make magnified view of this abdomen. See the umbilical vein which enters, and you can very well see the aliasing portion of the ductus venosus. Let me apprise before just 2-3 minutes when my time is over. And once you put your pulse wave gate over the pulse wave gate over the ductus venosus, you will get a good like configuration. So that's a typical M-shaped configuration of the ductus venosus. So you have nuchal translucency, nasal bone, ductus venosus, and then you have tricuspid regurgitation. So that's a third marker. So in tricuspid regurgitation, what you can do, have this view clearly visible of fourth chamber, and you put your pulse wave gate so that one crossbar above the tricuspid valve, one below the tricuspid valve without color. Please remember, without color, tricuspid assessment should be done. And then you put like this. So this is a mitral valve. I will put across the tricuspid valve, and what you get, that's an E wave, that's a A wave. Afterwards, your AV valve gets closed. So that's a snap of the closure of the AV valve. And then after closure of the AV valve, once ventricles are filled with the blood, they have isovolumic contraction period, and then ejection phase starts. And then you have closure of the semilunar valves, and then AV valve opens. So in whole this spectral waveform configuration, you can calculate isovolumic relaxation time as well as isovolumic contraction time also. So now this is about nuchal translucency scan screening for aneuploidy program. Now let us understand few concepts. When you have nuchal more than 3.5 millimeter or more, no question of any screening further by either serum biochemistry or NIPS. Straightforward, you have to do invasive. And you also carry out your anatomical defects assessment also in the same sitting. Genetic syndromes in case of previous history. And after that, you have stamped this baby euploid when NT is more than 3.5 or more. 20-week scan is normal. You can reassure the parents. See the statistics. When NT is between 3.5 to 4.4, 20% baby will be turned out to be chromosomally abnormal. 80% of those will be euploid. Now, out of this 80% euploid, 2.5% would die subsequently. 8 babies will have some kind of major defect after 14 weeks, and remaining 70% will be healthy. So what I am trying to tell you, when NT is 3.5 or more up to 4.4, once you stamp by invasive method that baby is euploid, this statistics must be explained. Don't reassure that everything would be normal. Sometimes if she gets included in this 10 babies, you will have a disaster. Now, when you have NT 3.5 or more and it persists after 14 weeks, you have a nuchal fold. Always keep in mind the infections, DNA testing for genetic condition. There is a risk of 10% perinatal death. You may have live birth with syndrome with no prenatal diagnosis. And you should also explain risk of neurodevelopmental delay in 3 to 5%. Now, Dr. Sunita ma'am has shown very nice figures of those anatomy. Anatomy should be tried as far as possible, best possible with your machine and with your skill. Dr. Khurana has opposed recently international guidelines, which they were trying to include ear and even in the lips and palate also in first trimester scan, which is not possible with every sonographer here in our country. So right from top to bottom, you have calvarium, falx cerebri, choroid plexus, then you have in heart 2 ventricular filling jets, a dash and dot appearance. You have limbs, 3 segments of each limbs, bladder, stomach, kidneys, which you can multiple things you can see. Try to see maximum things. And you can diagnose many defects where termination may be warranted. Anencephaly, holoprosencephaly, body stalk anomaly, ectopia cordis, like that. So these are the list of the anomalies which you can diagnose. Preeclampsia, madam has already told us that this is a good window to screen those women who are at high risk of developing fulminant preeclampsia, that is before 32 weeks. We are not much worried about those hypertension which are developing later on. We are much more worried about those early severe preeclamptic toxemia that you can carry out by uterine artery Doppler. So now let's see one video of uterine artery Doppler, where in transabdominal you can also do, transvaginal also you can do. That's a 12 weeks pregnancy. And once you have optimal amount of urine in the bladder, you focus on the cervix and how nicely you can see the uterine artery, which is ascending branch, which is going towards the uterus. And you put your pulse wave gate and find out what is the uterine PI and plot it into the software whether she falls into the resistant uterine artery or low risk for developing preeclampsia. So that's a preeclampsia assessment. Now, the incidence of preeclampsia in post-ART pregnancies achieved via IVF was 9% compared to 3.7% among natural pregnancies. So this is all about what I am going to, what I have highlighted regarding the first trimester scan for only aneuploidy. Now, as far as the defects are concerned, in our Wings Hospital in last 5 years, we have 8 cases of heart defects, 3 cases of occipital encephalocele, 2 spina bifida as a major defect. In addition, I would say globally, there is lack of data comparing the congenital birth defect of IVF cycles separately for autologous and donor oocyte. So these are the different data I have collected, but data is not having any consensus. Now in take-home message, just I would tell you that first trimester screen has saved many elderly mothers from invasive. Nuchal translucency detects 75 to 80% of the babies of trisomy 21. Optimally performed nuchal scan, first trimester scan nowadays it is known, tells you so many other abnormalities other than the trisomies also. And NIPS has changed the scenario a little bit of trisomy screening in first trimester, where people are now affordable. So you can screen those for trisomy at least for 21. See, 13 and 18, they are not mostly problems. 13, you can very well diagnose in ultrasound. 18 sometimes may deceive you, but trisomy 21 babies, where you have a fear of missing them, you can catch them up to 99% by NIPS. Thank you very much, ma'am, for giving us an opportunity to share our views regarding the first trimester scan by nuchal translucency. Thank you, ma'am.
Dr. Girish
Thank you.
Patel, really, it was very informative and practical talk. Really, we enjoyed a lot. And really, you have given a very minute points how to diagnose, how to detect so many problems. And only on ultrasound, you can follow your pregnancy very nicely and very precisely. Thank you very much.
Thank you. Thank you, ma'am.
Dr. Girish, hello.
Yes, ma'am.
Can I have
Yes,
a question?
Yes, officially.
Yeah.
Yes,
So what do you say? Suppose we do this first trimester screening scan transvaginally, it is more accurate, or transabdominally? Suppose patient is very obese or there is a big abdominal fat layer. So what would you say regarding the optimacy of the scan?
Okay, ma'am. If it is feasible with transabdominal, you must go with transabdominal. Now, as you highlighted in high BMI patients, if it is not feasible, we are taking by transvaginal, but transvaginal nowadays, mainly we are using for seeing the anatomy. Says, for example, in heart. In heart, we detect the situs by abdominal method and then see the anatomy, ventricular filling, jets, descent, dot appearance only by transvaginal. But as far as nuchal is concerned, you can take it by transvaginal. Doesn't matter if it is not feasible with transabdominal. But now you have a very good tool. You put them NIPS.
And I think another thing which is beautifully visualized by TVS is the cervical length.
Exactly.
But, yes, because sometimes like that is not exactly a first trimester, but sometimes you have pregnancy losses around 13 to 14 weeks of gestation, wherein you have to assess the need for a cervical stitch if required. So now there are so many schools of thought, and just in the first talk, before the first talk, Dr. Sunita Tandalwadkar was saying that a precious pregnancy, 40-year-old IVF twins, can you afford not to put a stitch? Because there are still some, the conservative gynecologists who feel, I have personally seen That was an era of progesterone. There are a lot of patients circulating between Indore, Gwalior, Bhopal in our state. I got a patient, IVF twins, reputed IVF center, respected center in Indore. She came to me. She called me up, Madam, pain is there and I want to visit you. I said, okay. She came at 12 in the midnight and on a pad, she was holding both her twins. She had just, expelled both the ICSI twins on the way. And the report she carried from Indore was a cervical length of 2.7, 2.8 centimeter. So sometimes, the dynamic, the cervix and the cervical canal are such dynamic structures. Suppose there is some myometrial contraction and the cervix becomes the passage and the internal os opens up. It's a matter of a few hours only.
Yeah, you are right.
Thank you, Dr. Girish.
Thank you. Thank you, Dr. Girish. Yeah.
Wonderful
lecture.
Thank you, Dr. Sushma, for joining. Welcome, Dr. Selva. It's lovely to have you here. And Dr. Sunita would have loved to see you, but I think Dr. Sunita has just left the meeting after her talk. She must be so busy with the Star Conclave now. So,
Girish, it was really a wonderful talk, Girish. It was really a great talk.
Good. Yeah. It was a great talk. Yes.
Yes. And Sushma, so nice to see you. I was wondering whether we are missing to see her, but good that she has joined, Sushma. Good. Yes.
So they are magic. You have got magic fingers, magic hands, Dr. Girish. All of you, I think. Dr. Ashok Khurana, Girish sir, Manish sir, magic in their hands,
We have blessings of our
mentor. It is not the machine, it is the man or the woman behind the machine.
Always the man behind the machine. And Girish sir, as you were talking, I was doing an NT scan. It was so nice to brush up all the basics, and I was just seeing if I was doing exactly the way you were seeing. Even my girls were listening. It was a very nice talk. Thank you so much for that. Briefing out everything and brushing up the basics of screening, sir.
Great. So can we proceed to the third session? Dr. Randhir can invite the chairpersons for the third session.
Yeah. Thank you, Dr. Monica. So I'll invite Indian Menopausal Society President from Bhopal, our senior, Dr. Shashi Srivastava ma'am. We don't have to introduce in the Bhopal, but now it's platform to the India. So I'll introduce her. She's one of the oldest hospital, I think more than 40 years in the Bhopal, Saurabh Nursing Home, because the main heart city, it's a Chandni Chowk of Delhi. So it's that area, a car cannot go. So still practicing from there. She is at present Foxy Senior President Bhopal Menopausal Society, life member of IMS, PCO Society of Foxy. Area of interest is recurrent pregnancy loss and sonography, polycystic PCOS. And she's a very good, she has got a magic in her hands to how to beautiful deliver a twin or single one. Welcome, Shashi ma'am. And next is our respected Vijay Lakshmi Verma ma'am. She's also a senior gynecologist. She is very academic. She's from Medical College and she's a gold medalist, many distinction in her career. And our old alumni from the Bhopal, recipient of 7 medals during MBBS. I have told you, she's a gynecologist, recipient of Best Student Award in 1982. She got, because in our MP Bhopal, we had a overall gold medal also, that is Kath Memorial. Myself and Dr. Monica also got that. Cleared ECFMG in 1983, participated in many CMEs and newsletter. Welcome, Vijay Lakshmi Verma ma'am.
Thank you.
So I think the third is Dr. Mayank Chaudhary.
Dr. Mayank is the speaker. Now,
yeah. So they will introduce,
okay. Okay, I'll introduce him.
Yes, ma'am.
Good evening and welcome to all the delegates of the conference. I welcome you to the 4th season of the ESAR Perfection Series.
Ma'am?
Okay, is it visible?
Yes, ma'am.
Okay.
Ma'am, sorry to interrupt. Can we, Monica ma'am?
Yes.
Yes, ma'am. Dr. Selva Priya ma'am is going in the case. So, ma'am is there for chairing this session.
Right.
Can we have?
Yes. Please, Dr.
Selva. So I'll introduce Selva. Just put a CV. Yeah. So, So Selva Priya is a very good friend, senior most, and obstetricians from the south. And she has got she has got the Spring Fertility Center, and she's the vice president in that Nagaraj Pali Obstetric Gynec Society. She's secretary of IFS South Tamil Nadu, Chairperson, Ethics and Medical Legal Committee, Tamil Nadu, Co-Coordinator, Foxy South Zone, Cell Member, Foxy PCP entity, and President Task Force Member, Social Media. She is very active in the social media, and I request her to chair the session.
Dr. Selva, you're muted. Dr. Selva, you're muted.
Fetal physician from Mayflower Women's Hospital. And if we have to highlight about him, he's trained in Mediscan, same as mine, from Suresh Sir's institution. And he's a top winner of Cow at Fetus Net 2013, 14, 15, 16, 21, 22. I don't know why he's left 23. I think it's still a little more time was there. And his special interest is with twins and fetal growth disorders in the first trimester of fetal disorder and fetal echo. So he belongs to the center. His center is recognized as basic and advanced training for antenatal scan. And he's conducted workshop for basic scan, fetal echo, color Doppler, and fetal intervention and fetoscopic laser surgeries. So with all this, I think we are having the right person to talk about the TIFA scan. And Dr. Mayank sir, we are so looking forward to hear it from you. Dr. Mayank sir, are you here?
Are you able to see my
Could you
screen?
please unmute yourself and just say hi to all? No, we're not able to hear you.
Are you
Is
able
he
to see my
audible?
screen? Are you able to see my screen?
Yes.
You're
Yeah,
audible. You're audible and you're visible, Dr. Mayank. Please.
Okay.
Yeah,
okay.
yeah, Dr.
Thank
Mayank,
you.
it's audible. Yeah, yeah.
Thank you. Thank you very much. Thanks for those word of introduction, Dr. Selva. The word today's agenda is the TIFA scan. It means targeted imaging of fetal functional anatomy. And today's perfection series mentor, Dr. Sunita Tendulkar, Dr. Nandita Palshitkar. And I am very happy to see Dr. Ashok Khurana and Dr. Nagori sir as a guest. And I'm very much thankful to all other who are present here. TIFA scan is synonyms used for a mid-trimester scan. Regards from Mayflower Hospital and my team. People only see what they are prepared to see. And first talk was on screening inverting of pyramid of antenatal care, and second talk was on first trimester. So the big filter has applied, and this has made my job easy. Now, if after so robust screening, if I see in a mid-trimester, thing will be easy for me. And in a TIFA scan, everything is regarding pattern recognition. You have to do lot of normal scan as per protocol. And when you see if there is any oops, unusual finding, and that is a hint for anomaly and a detailed examination. There are a lot of guidelines, and all guidelines are good. ESOC guideline, Society of Fetal Medicine guideline, Rule of 3, Fetal Medicine Foundation, ESOC guideline, all are good guideline. And once you are beginner, then you have to start with a guideline. You have to choose any guideline which is more comfortable to you. And then day by day, when you get competence, you should add yourself, you should push yourself further, and you should include more things in your routine scan. The rule of 3 is a rational approach to see the fetus in a mid-trimester. Why it is good, according to me, it can be applied in any basic machine and it consumes less time per scan. Even it can be performed in an unfavorable lie also. The learning curve is short and it is easily reproducible, and even in multiple gestation, you can achieve your goal of rule of 3. Rule of 3 is a 7-step to follow, and you have to see the baby in a 3 anatomical plane. And outer limit of various normal measurement is 10. 7 plus 3 is equal to 10. Outer limit of cisterna magna is 10 millimeter. Outer limit of pelvic LSL system is a 10 millimeter. Outer limit of a ventricle is a 10 millimeter. So it is there are a few more things where the outer limit is a 10. So we have to do step by step examination. The first step in any medicine is a history. Then you will go to survey, then biometry, basic biometry, and then you'll go for a targeted scan, system-wise examination or examination as per the risk. You will see the fetal movement, fetal environment liker, and at the end, there is a reporting. If baby is in a favorable position, it will take only approximately 20 minutes. And there are odd 36 images. The advantage of following any protocol or rule of 3 is if baby is in good position, you will able to finish it in a determined time, and there is a checklist. So if anything is missing, you can go back and check that according to checklist, and your detection rate will improve day by day if you follow this. And it is good for teaching, and sometimes when there is a oops postnatal finding, and when patient come that doctor, you missed this, then you can go back to those images and you can audit yourself. It can be used in research and reporting. General history, we will start with general history, LMP, obstetric history, medical history, family history. And this is very vital. If this can be taken by your staff also, but if you take, then it is good. It will create a rapport with your patient, and if that will break a thought cycle of a previous patient, because you are doing a lot of scan per day. The previous scan thought will mix with current scan. So if you talk with the patient, then it will be a good patient will identify, yes, my doctor has tongue also. And you can keep the room atmosphere light by some light music, because if patient is his patient tone is high, you will face a difficulty in scanning. So the during your scan, you have to tell in between, after 5 minutes or after 10 minutes, yes, I have seen this much and this is fine. I have seen this much, this is fine. If you communicate, the patient will also feel better, and the tone will decrease and scan will be easy. Your first step of actual ultrasound is a survey. You will put a probe. Before putting a probe, you will apply a jelly, and just for the sake of the spreading jelly evenly, you have to move the probe randomly here and there from left to right, up and down. And in that process of survey, you will able to see the global anatomy of the fetus. Rarely you will catch something with your plenty of year of experience. Even in survey scan, you will able to pick up something, and you will able to see the fetal number, viability, what is the lie of baby, where is the placenta, and subjective assessment of a liker. So survey is an important step of a scan. Then you will go for a very basic biometry, but actually you have to be opportunistic. Whatever the baby is showing to you, you have to see that and finish first. Suppose the spine is anterior, then you will first go for a spine, and paraspinal is a kidney, and para head is a ear. You can finish like this. If the baby is in a lateral position, spine is lateral, then you can go for a biometry. And if the baby's spine is posterior, you can finish the fetal face, you can finish fetal heart like this. And if baby is not that much cooperative, then go step by step, go for biometry and Doppler and rest of the thing. We will go for basic 3 biometry, that is the BPD HC, AC, and FL. And we will have a rough estimation of fetal age, either it is corresponding to fetal LMP or not. Already in early pregnancy, dating is done. So we will confirm that baby is growing well in this interval period or not. We will measure only metaphysis in a FL. And in late mid trimester, this is a near FL. The far FL may be since slight bowing, that is a normal physiological. And in a late trimester, the FL will appear slightly subtle angulation, again, that is normal. If you feel that there is mild bowing, then you can try the another view also in a FL after some time. And you can see in this BPD view that or transthalamic view, thalamus is seen. We are going to measure from outer to inner and from OFD outer to outer. This arrow sign is seen. In abdominal circumference view, the spine should be at 3 or 9 o'clock. Adrenal gland is seen, portal is seen, C-shaped or J-shaped. This convexity is facing toward the stomach, and 1, 2, and 3 line is seen here. 1, 2, and 3 line is seen here. Either you can measure in diagonal method or elliptical method, whatever it is a good, but diagonal is a preferred method, because in elliptical method it is quite very much tempting that you do some correction, and that will create a wrong habit. Rule of 3, we will divide the pregnancy in 3 parts. One is fetus, second is placenta and liquor, and third is a uterus. And we will divide baby fetus in a 3 parts. One is a head, another is a torso, and third is a limb. In a targeted scan, we will see the baby anatomy, and if there is any additional risk, then we will go for a detailed examination as per that risk. And classically, we will examine in sagittal, axial, and a coronal plane. We'll see the baby from head to toe, and we'll prove the normality. And if the scan is not satisfactory, then we will do a repeat scan, or if there is something in a scan finding, we have to go for a detailed scan. In a head, there are 3 views. One is transventricular, second is a transthalamic, and third is a transcerebral. Transventricular is on top, then comes transthalamic, and with slight rotation, you will be able to get a transcerebral view. In transthalamic, you have to see 3 minimum thing, that is, one is a midline falx, another is a rectangular shape cavum, and the thalami, which is creating a arrow shape. Falx is interrupted by cavum in a anterior part, and cavum septum pellucidum is somewhat rectangular shape, and thalamus will create a arrow. The BPD is measured from outer to inner. We will avoid skin and hair, and correct measurement technique is shown here. There are other technique also for the BPD. You can measure from middle to middle or outer to outer, but you have to use those nomogram. Conventionally, more than 90% of people measure from outer to inner, and OFD outer to outer. Coming to transventricular plane, we have to see 3 minimum thing. One is a posterior horn of lateral ventricle, another is a cavum, and third is a choroid plexus, hyperechoic choroid plexus. So in cavum, again, it should be rectangular in a shape, and a choroid plexus, at the level of choroid plexus, you have to measure a atrium of a lateral ventricle, and after 21 weeks of gestation, you will be able to see the calcarein, and you have to measure at that level, and you have to take care that you will measure the perpendicular to the axis of ventricle, but not to the perpendicular axis of a midline falx. If you measure with a perpendicular to midline falx, there will be 1 or 2 millimeter will be higher. And you can see this is a far hemisphere and this is a near hemisphere. And near hemisphere is a hazy, that is suggestive of a good mineralization of a skull bone. And that is due to reverberation artifact. And it is our duty to see another side ventricle also. You can angulate the probe and see that. And in coronal plane, both the ventricle is seen easily. You are going to measure in to in like this. The rest of the measurement, these are incorrect technique, and this is calculating. You have to measure at that level. Before 21 week gestation, it is not seen, so you can measure at the level of a choroid plexus also. In transcerebellum, again, view, you have to remember 3 things. One is cerebellum, second is midline echogenic vermis, and cystic area behind vermis, that is a cisterna magna. The cerebellum should be figure of 8 shape or dumbbell shape, and echogenic vermis will be seen, and posterior sometimes haziness is seen, but that is again a normal septa. In high resolution machine, you will be able to see the septa in cisterna magna. That is a normal finding. This is my favorite view. I take additional biometry here, also transcerebral diameter, and by looking that you will able to rule out big open spina bifida, and this is the same view where you are going to take a nuchal skin fold measurement. And when we are not able to get this plane properly, then you can angulate a probe slightly so you can see the end point of occiput and nuchal skin fold. Otherwise, many times what will happen, there will be shadowing of occiput and you will not able to get a clear endpoint for the measurement of a nuchal skin fold measurement. So how to get all those, this view, you have to go to head and try to make the whole head oval and then try to make the midline facts horizontal. In this process, automatically you will get all these three view. Just you have to create head oval and make midline facts horizontal, then freeze. And if you go frame by frame, you will get a head view. If you want to push yourself more, you have to see the sylvian. You can see the sylvian here, and you can see the sutures also here, and you can see the posterior shadowing from the edges of the skull bone. That is suggestive of good mineralization. Coming to the spine, both lamina and body are parallel, and in thoracic and lumbar vertebra, there is a widening at the level of cervical vertebra, and there is subtle widening at the level of lumbar vertebra also, and you have to observe sacral tapering. You can see here sacrum is a taper. So here we are able to see the 1 skin line, 2 lamina line, 3rd body line. And if you trace here, it is seen throughout. But at this place, we are not able to see the lichar. So we will store this image, we will wait for some time, and with the movement of probe and with the movement of baby, you will able to see the lichar also. If image is like this, this is a good image than previous one. First line skin, 2nd lamina, 3rd body. And you can see, appreciate this sacral tapering very well here. Spine can be seen in coronal scan also. It looks like a railroad appearance, and spine can be seen in axial also. But for elicited this all 3 dot in coronal scan, you have to rock your probe, and gradually you have to move from head to rump or rump to head. You will face some difficulty at the level of scapula. Again, at that level, you can angulate the probe and you can get the midline ossification of a body in a coronal scan. This is a case, you can see here, tapering was not seen, sacral tapering was not seen here. And you can see this meningomyelocele, and baby is trying to hide his weakness, is covering, baby is covering his hand on that weakness. And here this is not rupture, so the head is normal, there is no ventriculomegaly, and posterior fossa is normal. So normal posterior fossa, you should not assume that spine is normal. You have to see the spine directly, and then only you have to declare that spine is normal or not. If this is rupture and leakage of CSF fluid, the posterior fossa will become abnormal later on, and there may or may not be ventriculomegaly. The classical lemon and banana sign appears in a extreme case where there is a CSF leakage. Now coming to the thorax, again thorax is divided in the left lung, right lung, and midline. There is a heart, 3 things to remember. And heart occupies 50% area of a thorax, and apical 4th chamber and lateral 4th chamber will give you maximum information. If you are examining heart in basal 4th chamber view, that is not a good view, and please wait for some time or do some maneuver to make it apical or a lateral. If during examination of heart and thorax, if you are able to see more than 2 ribs like this, you can see here 1, 2, 3, 4, and that will create a lot of artifact inside the heart, and they can mask information. So not more than 2 ribs should be seen while in AC section, also in an thorax cardiac examination. Also in a sagittal plane, you can see the diaphragm, but intact diaphragm does not rule out a diaphragmatic hernia. That thing you have to remember. This is a case of diaphragmatic hernia. You can see in a video, the stomach is completely inside the thorax, and in 4-chamber view, axial view, you can see some cystic shadow beside the heart. Heart is completely pushed on other side, and half of the stomach is in abdomen, half of the stomach is inside the thorax. This is another case of diaphragmatic hernia. While process of taking a view of a situs, you can see this is a heart, and in this 4-chamber view, the stomach is seen just beside the heart, and it is not seen in the situs view of a abdomen. In the same patient, you can see the diaphragm which appear intact. So if intact apparent diaphragm in longitudinal view does not guarantee that there is no diaphragmatic hernia. Diaphragmatic hernia is an indirect diagnosis. The absence of stomach shadow inside abdomen or below a diaphragm, and presence of cystic shadow inside the thorax, along with a excess deviation or the pushing of the heart. This is a case of cystic adenomatous malformation, mixed variety. You can see again here the heart is pushed on another side, and the echogenic lung tissue, and along with that, the 2 cysts are seen. This is another case. They come at 19 weeks for the termination. You can see in the 4-chamber view, one side lung appear echogenic and another side lung look normal. We counsel the patient that this is a typical time of appearance. After 17 weeks, the CECAM appear, and the peak is around 24 weeks, and after 28 weeks, majority are regressing. So in the process of this counseling, they agree for continuation of pregnancy. And you can see, we call the patient at 24 weeks, this lesion was there, but at 29 weeks, there was no telltale of cystic adenomatous malformation. The heart, which was pushed in a previous scan, now it is at completely normal location, and in thorax, we are not able to see anything. So when the anomaly is diagnosed, it is not that it is an indication for a termination. You have to give the information to the patient, and parent will decide for the continuation of pregnancy. And if they are in search of hope, you should give a hope. So always it is a team approach, and outcome depends on how teamwork is there. In a motivated parent, you have to go send patient for counseling to specialist. Suppose there is a cardiac lesion, send patient to cardiothoracic person. Suppose there is a limb lesion, then send patient for counseling to orthopedic. And whenever there is a need, do genetic investigation. Definitely that will change the management of that baby, and it will have a good outcome. Coming to the heart, it is not the detailed discussion of heart is beyond the scope of this talk, but just I will tell you, remember the 2 acronym. One is a PASS and another is also PASS. PASS is for 4-chamber, that stands for position. Position of heart is somewhat middle and the left side. Axis is a 45 plus or minus 20. You have to draw imaginary line in an interventricular septum, and another line from sternum to spine, and that is 45 plus or minus 20. If there is a left axis deviation, most probably there is a cardiac outflow tract anomaly. If it is a right axis deviation, most probably there is a diaphragmatic hernia or other space occupying lesion inside the heart. There are a possibility of rare thing also. Then third important is a situs. You will take one image at the level of abdominal circumference and another at the level of heart, and you label spine, stomach, portal vein, and if it is in clockwise direction, the baby should be in cephalic position and the heart should be on the same side of stomach. Immediately you have to confirm that whatever you have assumed that is correct or not, and then situs is confirmed. You will have a sweep from abdomen to neck, and in that process you will start from abdominal circumference, then gradually come towards the neck, and then again after this is a survey of heart. Then you will come for detail of a 4-chamber view, and then detail of a 3-vessel view. What you are going to see that symmetry of ventricle and symmetry of atrium and a good squeeze. As per ESOC guideline and SFM guideline, there are many more things to see in a heart, but again, that is beyond scope of this talk. In 3-vessel view, the name itself, 3 is there. There are 3 vessels. The most anterior is pulmonary artery, and then is aorta and superior vena cava. They are juxtaposed. There is a specific arrangement and alignment. If you describe from left to right, it is a big comma, small dot, and smaller dot. And if there are 2 vessels in 3-vessel view, or 4 vessels in 3-vessel view, or there is abnormal alignment or abnormal size, then there are that is a hint for outflow tract anomaly, and many times 4-chamber view anomaly also. If you apply Doppler, definitely it will give a additional information. I will not go in detail, but apical 4-chamber view give a maximum information. Now coming to the abdomen, as per rule of 3, upper abdomen, mid abdomen, lower abdomen. And in upper abdomen, you have to see the stomach, portal vein, and a liver. In a mid abdomen, you will see right kidney, left kidney, and a bowel. If you are not able to find anything in a bowel, if bowel are unremarkable, that is considered as a normal bowel. And in lower abdomen, you will see bladder, perineum, and paravesical umbilical artery. Again, the paravesical umbilical artery, there are 3 vessels as per rule of 3, 2 artery and 1 vein. And there should not be another cystic shadow apart from bladder and stomach inside the abdomen. And many times now gallbladder is also seen due to high resolution machine. So in a mid abdomen, this is a bowel which looks unremarkable, which is considered as a normal. You can see the cord insertion also at the same level. And you have to see the both side of kidney in a coronal and a sagittal plane. But for the sake of measurement of pelvic LSL system, as per FMF guideline, you have to see both the kidney when the spine is at 12 o'clock position. And you have to measure pelvic LSL in the anteroposterior direction like this. And as per the measurement size and various finding, you will classify in a high risk and low risk as per U2D classification. Once you see the kidney, just you will put a Doppler, and Doppler may help you in a difficult situation. But in early pregnancy, this can be substitute. But in mid-trimester anomaly scan, please remember my word, you have the kidney only in a grayscale, and don't assume such type of renal vessel that both the kidney are present at their respective location, because superior mesenteric artery and other vessel, if you are not in a proper plane, can exactly create artifact of renal vessel. So in mid-trimester, if you have to see only kidney in a grayscale, and grayscale, please remember this. In lower abdomen, you have to see the bladder, paravesical artery to umbilical artery, and you have to take a Doppler at the free loop of an umbilical cord. You have to see the placental side attachment of the cord. You have to see the fetal side attachment of the cord. And you have to see the perineum, and perineum is well defined or not, that you have to also see. As I told you, there should not be another cystic shadow beside stomach and bladder and abdomen. Here you are able to see the another shadow beside the stomach. This is double bubble sign with a polyhydramnios, and you can see this bubble are in communication with each other. This is a case of a duodenal atresia, and when there is a duodenal atresia, there is a high chance of aneuploidy. We have to do invasive test in this parent, and there are rare chance of Leeds band, which is completely normal, or annular pancreas, which also can create exactly same double bubble sign. Now, this is a gonadal cyst due to PNDT law, we are not able to tell a ovarian cyst. And there should not be another cystic shadow beside bladder and stomach, only 2 cystic shadow in abdomen, but here there is one more cystic shadow. And in this gonadal cyst, you can see the fluid and solid level. This was internal hemorrhage inside this gonadal cyst due to twisting or whatever it is. And baby was delivered at a term, and outcome was good. After 7 days of postpartum, this cyst completely resolved in end. This is the typical history in majority of case. This is a distended bladder and dilated urethra, which is creating a keyhole appearance. This is a Luto group of disorder. When such type of finding is there, there are changes in a kidney also. This kidney appear echogenic. You can see dilated pelvic ileus system along with the hydroureter reflux. You are able to see here. The prognosis and management is complex in such type of lesion. Coming to the extremity, you have to remember 3 things as per rule of 3. You have to see the length of a bone. You have to see the shape. It should be predominantly straight, and echogenicity. How you will elicit echogenicity? There will be a posterior shadowing behind this long bone. In that way, you will be able to see the mineralization. You have to see all 3 segments, that is a proximal, middle, and distal segment, and posterior shadowing is suggestive of good mineralization. You have to see the opening and closing of hand. Constantly closed hand in a early pregnancy is equal to anomaly, and constantly open hand in a second trimester is equal to anomaly. So hand should open and close, and you have to see that, and subjective assessment of muscle mass also you have to do. You will see the ankle, both the ankle, and you can see in the process of seeing tibia and fibula. And while seeing the tibia fibula, the sole of foot should not be seen. If it is seen, then that is a suggestive of a club foot. And if there is a abnormal finding, you have to reproduce in a different time frame, because if the foot is near fundus or near uterine wall pushing, many times it can create a positional artifact of club foot. So abnormal finding, you have to reproduce in a different time frame. And this is a shortcut for rule out club foot. If you are able to see both the sole of foot like this side by side, almost that will rule out club foot. And in that case, if you do not document that previous image of tibia, fibula, and foot, then also you can assume that there is no club foot. You have to measure a foot length from heel to the second toe like this. You will not measure from heel to first toe. That is the incorrect way of measuring it. You will not go exact counting of finger, but opening and closing of a hand is suggested. Exact counting of finger is not recommended in any guideline in a low risk population. But if there is another finding, if the high risk population, in that case, you have to count at that. Coming to the fetal face, you have to see 3 things. One is orbit, second is nose, and third is mouth. Orbit is best visualized in an axial plane, and this is a good view. Many times we use semi-coronal view, we just see the round eye lens, but this view will give you maximum information, because if there is a subtle unilateral microphthalmia, that can be easily depicted in this axial view. And another thing which you can see here, this is approximate of this eyeball, approximate size of this. You can compare left and right better in this view as compared to the coronal view. And if you are able to put this eyeball here, just it fits snugly, then it will rule out hypo and hypertelorism. If you are able to put this eyeball, 2 eyeball here, then it is a hypertelorism. And if you are barely able to put this eyeball here, or if you are not able to put it, that is a hypotelorism. And this nasal bone, this level will be higher than this eyeball, and that is just again additional information. And if this eyeball is ahead of this ossified nasal bone, then that is a hint for proptosis. So a lot of information is there in this view, and you should document in an axial view only. Nose is better seen in a sagittal view, and lips are better seen in a semi-coronal view. And subtle opening of mouth you should observe. I am not saying that you observe a yawning of the fetus, but subtle opening of mouth is recommended. That you have to wait for at least that much time. The nasal bone is better depicted in this sagittal view, and while measuring nasal bone, the head should not be in a hyperextended position. Hyperflex will be okay, but if it is hyperextended, then it will create an artifact of absent nasal bone. So you have to remember that. Mouth, you have to see in semi-coronal plane. You have to see the upper vermilion border lip. You can see the line, and you can see the ala of nose also. And ala of nose appears symmetrically placed from the vermilion, and it looks even if you are not able to see any one side of ala of nose, that is suggestive of a big cleft lip palate on that side. And if you are struggling for both side of ala of nose, that can be a hint for a big midline or bilateral cleft lip palate or a binder faces. So the subtle small observation is also important in your scan. This PMT is a substitute for a rule out a cleft palate, but it is just a initial assessment. You have to see the lips directly whenever the hand or cord is not there in front of face. So PMT view, please remember, is not always a substitute to rule out a cleft palate. Here we can get additional information of a mandible also, and this is just a subtle opening of mouth, and you can see the both the ala of nose is same at a same level, and that will rule out big cleft lip palate, not a smaller one. This is a case when you can see the bilateral club foot, and you can see here while visualizing tibia fibula, the sole of foot is seen on this side and another side also. So the appearance of club foot will be like this, and this is a 3D rendering of a same, which is very well seen in 3D rendering also. This is another case where there is a big cleft lip. You can see we are struggling to see the ala of nose, and there is a big cleft upper lip, one side of upper lip, and midline is defective. In the same baby, there is a rocker bottom foot also. You can see the prominent heel. This tibia should be inserted somewhere here, but instead of that, it is in a middle, and you can see the shape of foot also is altered. You can see the insertion of tibia fibula in a 3D also. And just like a rocking chair, this shape is slightly curved also, and there is a vertical talus. In fetal activity, 3 things: fine and coarse movement, flexion and extension, and many times you will able to see the fetal emission also, and this good movement is suggestive of fetal oxygenation. Coming to the 6th step, you in a rule of 3, you have to see the placenta, liquor, and a cord. And in a placenta, you have to see the location. If the upper edge of placenta is reaching to the fundus, that usually rule out a low-lying placenta or a placenta previa. You have to see the echogenicity of a placenta. This is homogeneous placenta, and you can see the hypoechoic line in a retroplacental area, that is a placentomyometric interface, Netabush layer, or a placental bed vessel which is creating that hypoechoic band. Liquor, you can see subjectively. In mid-trimester, we use a maximum vertical pocket, and after 28 weeks, AFI is usually practiced. Many people use AFI in mid-trimester also, but we do not find it good, and we are advocating a single pocket here. Again, you can subjectively see the liquor if you are able to see put one more fetus beside this fetus, then it is a good liker. If you are able to see put more than one fetus beside that fetus in that uterus, then that is a polyhydramnios. And if you are able to barely put another fetus, or if you are not able to put another fetus beside that fetus, that is a polyhydramnios. That is subjective assessment. And a cord, you have to see cord from placental attachment. Then random assessment of free loop, you will take a umbilical Doppler and the fetal attachment. At the last, you will see the cervix, and the cervix by TVS only. Never try by transabdominal. That is, there are a lot of fallacies. We will not go in a detail. You have to see the length, and either there is funneling or not. And you will measure from external os to internal os. If your machine resolution is good, you have to measure from endocervical gland wherever, from lower margin to upper margin. Or another reference point is a reflection of bladder peritoneum. And nowadays there are a lot of cesarean section. You can see the level of cesarean section also. You can use that reference for the measurement of cervical length. And please do not include, this part is of lower segment, please do not include the cervical length measurement, otherwise it will give a erroneous report. At the end, reporting is must after every scan and should reflect your finding and inference from each steps, all the 7 steps. And you have to give a clear, meaningful message, and no negative reporting like the no evidence of hydrops, no evidence of club foot, no evidence of meningocele. Please do not include this thing in your report, because there is no end of that. Only mention what you have seen. And you should have a habit to keep a checklist behind the machine in initial period, and the later this will happen at a spinal level. And now the software are available. Just take image, put image at proper place, and software will tell this is missing, or this image is suboptimal, go and take another image. So you have started from history, you have finished survey by applying a jelly on a fetal abdomen, basic biometry, then targeted scan of fetal organ in standard plane. You have seen fetal activity during this and fetal environment, and at the end there is a impression. And again, to repeat, you have to be opportunistic. You have to finish few things when the spine is anterior. You have to finish few things when the spine is posterior. This thing you have to remember. And there should not be any shortcut while examining, like seeing the eye lens in a coronal view. There are suboptimal information, so you have to see the eye lens in only axial view. And part which is not seen, you have to inform clearly to the patient. You can get patient for a review after a few hours or a next day also. And you have to mention and explain this thing to the patient. You are in doubt, you can refer a book. It is not that you will remember each and everything and everything will be on tip of your tongue. No, that is not possible. But yes, protocol should be your rule of 3, or any guideline protocol should be in your tip of tongue. That is that I am insisting. You can ask the help of a senior. Now there is a WhatsApp era. You can share the image, or that person can see the live also, and you can take a second opinion like that also. There are a lot of limitation of examination due to fetal position, or now in India we are facing the problem of lower abdominal, previous LSCS scar, previous surgery scar, and lot of things are there. You have to wait. If you will wait, gradually fetus will change the position and give you position, or you can empty bladder, or you can do full bladder, or you can do left lateral, right lateral, and definitely you will able to complete the scan not in 20 minutes, but in 40 minutes or 1 hour. You will definitely able to do it. And please remember, sonography is not magic. It is a screening test, not a diagnostic test, and there are a lot of limitation, technical and practical, and sonography will not have a predefined duration. Thank you very much. I think I'm crossing my time, so I will stop the presentation here. Thank you very much.
Thank you so much, sir, for such a wonderful session.
Thank you so much. Because the target imaging is a really target imaging for the fetal anomalies. What I say is the important scan for the journey of the antenatal care. And it is the most important scan in the antenatal care life for the fetus as well as for the parents also. So I feel, Dr. Mayank, you have elaborately tell about the rule of three. It is a wonderful wonderful expression about the rule of three. I thank you so much for this opportunity, providing me to chair the US session. It is an excellent one.
Thank you. Thank you, Chairperson.
Over to you, Vijayalakshmi Verma, ma'am. What is your opinion about this session to conclude?
Thank you, Dr. Mayank. It was excellent. It was excellent speech, and he has explained everything from top to bottom very well. And we all know that some defects will definitely need termination and some defects need management immediately after delivery. So we can do this if we previously know everything about the defects and prepare the couple and the whole family to face this situation. Thank you so much, Doctor.
Thank you, madam.
Dr. Selvapriya, ma'am, you want to say something about this?
Yes, Dr. Mayank sir, it was really nice, and the emphasis you put on this reporting was really impressive, because I always think that the man is important, the machine is important, all are important, but whatever you put on the papers, it's something which is going to reflect your quality of work, as well as those are the papers which are going to save you in the court of law, or even get you cornered. And also, while doing scans, I always think that however we use an advanced machine and we talk about the rarest of rarest things, we should always keep in mind we are not superhumans. But we when you miss something very rare, rarest of rare, we are excused. But something basic cannot be excused at all. So when I started doing the scans, and when I was completely from OBG to fetal medicine, it was so difficult as an obstetrician to do all these main things. But like Suresh sir used to say, I went and told him I'm quitting, I don't want to do this. He said, see, there might be 1,000 abnormal things. I understand. But there is only one thing called normal. So why don't you master that normal? If you know what is normal, anything which is not normal, you are going to definitely identify that. That's what I would like to tell to everyone. There might be a lot of abnormalities, but we are not affordable to do any mistake in the basics. Nobody's going to excuse us. So if we follow this kind of system, whatever he's told, like it's been ages and ages of doing all these scans, I am still writing the same forms. We are still filling the checklist. There's somebody sitting and doing all that. So it really works, and it will give you that confidence. And thank you so much for just giving an A to Z of TIFA in all ways possible. Whoever is doing scan and whoever is just reading a report, they will know the emphasis they have to pay on each and every line, word, and section. So thank you so much.
So thank you,
Dr.
sir.
Selva.
Thank you, Shashi ma'am. Thank you, Vijayalakshmi Verma ma'am.
Thank you, Dr. Mayank. It was, we are, honored and we are very lucky to hear such an elaborative. I've heard so many talks on anomaly scan, but this is one of the best. Though I could attend only bits and pieces because of some coordination. But I'm so thankful to Dr. Manish Pandya for giving us the diamonds of Gujarat. I think whole Gujarat is full of diamonds. It's a diamond mine. But you people are the real diamonds of fetal medicine. And we are blessed to be your students. And just one question I have for all three of you. Does the machine matter? Because nowadays the youngsters, they feel that all good machines, they are starting from 20 lakhs. Then as you go 25, 30, 35, 40, then there is no end. So does the cost of the machine matter when you are entering into the field of fetal medicine?
In
Yes.
difficult and challenging
say
case,
cost,
yes,
teach.
for basic, it is not needed. For basic thing, it is not needed, but it will add the comfort of operator. The operator will be at ease. And definitely there are few things like first trimester, fetal heart, where this machine, the high-end machine will make a difference. But for the rest of the routine thing, it will not make a much difference.
So this is important because nowadays youngsters, they feel that they have invested so much in the ART center or their clinic or endoscopy center. So let us keep a machine of 15, 20 lakhs and start. And then when you buy back that machine and you buy a very superior machine, the previous machine goes for peanuts. So it is better to wait and watch and go for a better machine right from the beginning. Plan in advance if you are entering into the world of fetal medicine. I think that is my advice because I have made the same mistake when I was younger.
Thank you, Manish Bhai, for identifying us as a gem.
You are gems. We are calling Perfection series. We have only diamonds.
Madam, in Gujarat, we have got sugar and we have got diamond herbs, and these are diamond picked up by Delhi person. Dr. Khurana is the diamond of all because he had picked up so many diamonds, and I see that how he had built up fetal medicine. He was carrying the receipt book with him and just telling everybody, now you have to become member of Society of Fetal Medicine. That much hard work he has done, and now we see it is growing like big tree. So good kudos to Dr. Khurana. Love you, boss, for giving us such very good diamonds from Pan India.
Thank you very much. Thank you indeed.
Manish sir,
I'm so proud of them.
Manish sir, you will have to give credit to me. Manish sir made one phone call that Dr. Monica, you become member of SFM, and I sent that payment immediately within 1 hour. And I became a member.
So Dr. Monica, Dr. Khurana, she had started her interest in fetal medicine. So the fetal medicine first school from elementary to PhD is Society of Fetal Medicine.
Yes.
Thank you. That is true. We do our best.
So from elementary to PhD, it is Society of Fetal Medicine.
Yes, definitely. So that was the end of our talks. And the color Doppler talk is, we are short of time also. And the speaker is, because of some inevitable circumstances, could not join, Dr. Vaishakhi. So I would now request Dr. Purnima to take us to the panel discussion as Dr. Aparna madam has joined. Welcome, ma'am. So nice to,
Hello.
nice to hear.
Hello, everyone. Good evening, Khurana sir.
Good evening, good evening, ma'am.
Hello, Patel sir. How are you? Hello, everyone. Nice to be here.
Ma'am, I'm Dr. Monica Singh, co-convener for this series, and Dr. Purnima is my program coordinator who has been troubling you quite a bit. So, ma'am, so it is our pleasure to introduce Aparna. Please, can we have the CV? Dr. Vishal? It is my immense pleasure to welcome Professor Dr. K. Aparna Sharma from AIIMS New Delhi, who is Masters in Maternal Medicine from Barcelona University. She is a professor in the Department of Obstetrics and Gynecology, AIIMS New Delhi, maternal fetal medicine specialist with expertise in fetal interventions, secretary of the Society of Fetal Medicine from 2022 to 24, North Zone Coordinator, Safe Motherhood Committee, FOXI 2020 to 2023, chairperson, AOGD Quality Committee 21 to 23, and is the proud recipient of the Kamini Rao Orator Award in 2017, FOXI Junior Korean Award in 2018, FOXI Sun IAEC International Traveling Fellowship in 2019, and FOXI Imaging Science Committee Award in 2019. And last but not least, the prestigious FOXI Rajat Ray Award in 2022. Ma'am, we are honored. You have so many accolades. So many awards have been given to you, but we are blessed to have you as a moderator of a panel, which is of paramount importance to the clinicians of today's era.
Thank you everyone for having me here today. It's indeed an honor to be, a part of this program, and I'm very so happy Dr. Khurana is also here, Dr. Patel sir, senior people from SFM, and the new, also the fetal medicine specialists from Gujarat are here. And like that, there's so much of discussion happening around the diamonds. So the diamonds of Gujarat are here. So really nice. I heard the last talk. It was brilliant. So can I be allowed to share my screen, please?
Yes, ma'am. Technical support. Can you give the sharing right?
You have to stop sharing. Yes.
Yeah.
Thank you. So we'll have a very, we'll have a panel which would range from very basic questions to what is new in aneuploidy screening. So I think when we talk about aneuploidy screening, I think this is the bread and butter of the fetal medicine specialist. So I think we should know this completely inside out, right? So we'll talk about the basic questions from basics to advanced and the questions in between. So, just talk about it. And we have a stellar panel with us. I think we'll know each other more, as the panel goes on and interacting for the first time, but I'm sure we'll have a great time talking to each other on these common topics. So there are certain questions which come to our mind when we started talking about aneuploidy screening: which test, whom to screen, and the most important part is pre-test counseling. How do you interpret biochemistry positive? What to do with the NIPT is positive? What is the role of expanded NIPT? And how do you do screening in twins? So with some of these questions in mind, so let us go one by one and, start with a very basic question, that she's a very normal pregnancy coming in at 26-year-old primary gravida. So Dr. Manish, would you offer aneuploidy screening to her, and why would you like to offer aneuploidy screening?
Thank you, madam. Thank you, Monica, madam, for giving me opportunity to be a part of this perfection series. And madam, this is basic question. 26 year, as such, it is a low risk for the primary gravida, but we have to ask the history study of past in light of presence to have good future. So if they has got family history of trisomy or down, we can give them the advantage of NT nowadays, because NT, after having FMF training, you see NT is not taking too much of time, and NT is giving too much of information. Rather, false negative NT is very good rather than false positive NT. So we have to give them the benefit, but now make it a protocol, because as you said, aneuploidy screening is the bread and butter of fetal medicine specialist. I would say fetal medicine is evolved after aneuploidy screening.
Yes.
Before that, we are just doing first trimester and second trimester.
Absolutely.
Training.
I completely agree with you, Dr. Manish, and you're very good with your words. I think I just loved the code that you gave in between. But yes, I would say that.
So it is better to give them the advantage, and it is now should be included in our routine screening. Once you are doing CRL screening, at that time, just see the NT, see the nasal bone, see the tricuspid regurgitation. It is not very difficult. And Monica, madam, now you have started practicing fetal medicine. You will see that it is difficult at all, or yes or no?
Yes.
Madam, it is easy.
Totally.
Yeah. So I agree with Dr. Manish, and I think we should, although we do believe that an elderly woman has a higher chance of having a child with aneuploidy, most of the children with aneuploidies are born to younger women, just because more number of younger women become pregnant. So I think, like what Dr. Manish is saying, it should be like our reflex that we are offering aneuploidy screening, like hemoglobin, blood group, we offer aneuploidy screening. So I think that should become the norm, and that is what all the societies say, that regardless of age should be offered a screening through an informed counseling process.
The floating rate.
Can I request everybody to please
Dr. Mayank, please
mute yourself, Mayank.
Dr. Mayank, sir.
So all pregnant women, regardless of age, should be offered informed counseling and option of prenatal screening for the most commonly clinically significant aneuploidies. Now, now we come, okay, we are all agreed that we should be offering. So what is your practice? So remove the obstetrician part. As a fetal medicine person, what would you offer? Serum biochemistry alone, ultrasound alone, combined screening, or NIPT?
So, ma'am, this patient is a 26-year-old primary, and as we discussed in the previous question, that this modality of screening in the first trimester should be now made a part of our evaluation of this woman. So in my practice, I do an ultrasound in which I try to evaluate the NT, NB, TV, DV, and TR, along with the site of the future placenta, the cervical length, the mean uterine PI. I do it all at the initial scan between 11 to 13.6 weeks. At the same time, I counsel the patient, and if she is willing, I take a sample of the maternal blood and send it for the dual marker test. And I also asked her about her family history, any previous abortions.
Right. So Dr. Monica, you're saying that you will go for an ultrasound along with a biochemistry, which would be dual marker. And you're very correct because it has a very reasonable, good detection rate of 82 to 87%. Right. So I think like what you're saying is a detailed ultrasound, an ideal practice along with a biochemistry, which is a dual marker. Right. So this is what you would offer. And I think everybody of us does the same thing. And I think we have two points very clear: offer aneuploidy to all, and first FTS or first trimester screening to all. Now starts the confusion. Now, what happened is very recently, there is this lady who comes to me at second gravida, and she's a previous pregnancy. She was terminated at 18 weeks for possibly a Down syndrome. And when I looked into her record, it showed that a quadruple marker of 1 in 109, and her pregnancy was terminated because her screen was positive, right? Now, we know that screen positive does not mean affection. And it has been seen that in India, it has been reported that actually 10% would undergo termination without a confirmatory testing. And this is a report it's an original article which has been reported from India itself. So my question to Dr. Usha would be that, how important is pre-test and post-test counseling? And I don't know if you have come across such cases in your personal experience, but I have, right? Women becoming so anxious after a screen positive that, okay, doctor, mere to pehle bachcha hai, mere pregnancy terminate kar do, right? I don't want to go ahead and take the risk. So Dr. Usha, what is the, pre-test and post-test counseling that you would offer and insist before you actually tell that, okay, go ahead and do the test? We have
Dr. Usha is there or not, Purnima?
Hey, she's there. You need to unmute.
Okay.
Yes.
First, once the screening test is positive, we should confirm it by amniocentesis. She's 12 weeks. We will confirm it by either by CVS or by amniocentesis. If confirmatory test is positive, then only we will go for termination.
Yes, ma'am. So exactly. So the point that this is just a screening test, so that should be emphasized. So it is not like a blood test that aap jao hemoglobin kara lo, right? Aap jao, because these labs, they will highlight it in red that something has come to be abnormal. So why I have taken this point is the importance of pre-test counseling when we are offering aneuploidy reports, aneuploidy testing, and that should be offered by ourselves to everybody, that there is a specific risk, discuss the risk, limitation, and benefits. And we have to say that if it is positive, we need to offer them additional testing, right? We need to offer them additional testing, and there is a likelihood that the fetus may be absolutely normal. If the test is negative, the risk is low risk. There is always a residual risk. So a pre-test, post-test counseling is very important when we are offering testing for aneuploidy. Please remember, it is not like a blood group or a CBC testing where you just offer when you prescribe a test and not talk about it. So all these events where women go for testing and go for termination without a confirmatory test happen because we are not probably doing adequate testing. Now moving on to more, in between questions. So Dr. Ishrat, I would say the same patient, would you offer NIPT for her? Would you say that, okay, what is your approach to NIPT? Like would you keep it like tightly inside your purse and like a secret weapon to be used when the time comes, or you offer it liberally to everybody? I mean, people might differ in their options, but what do you do?
You're muted, Ishrat.
Dr. Ishrat, you need to unmute.
Am I audible?
Yes.
Yeah, good evening all. Basically, in my practice, I am not very open up for NIPT. Basically, my approach is same. If I take the history, definitely a 26-year primary is a low risk for me. So I start with the basic ultrasound, NT scans, and ruling out the other marker like NBDV, PR. And I will definitely go for the biochemistry and decide accordingly whether it is intermediate risk, or then further if it comes in the intermediate risk, then I advise her NIPT. Commonly directly in my practice, I do not advise NIPT directly, but nowadays as the cost has reduced, so we can offer theoretically, but practically in my practice, because of the cost concern, so I do not advocate it routinely.
Yeah, and I completely agree with you. See, theoretically speaking, when we say that, okay, what is the ideal, what is the standard, we say that NIPT ACOG recommends at a secondary screen when the woman is more than 35 years, or there is a suggestive history, or the screen is positive. So when you have a secondary screen, as a secondary screen, NIPT has a role. As a low risk, maybe currently none of the guidelines would advise primary screening by NIPT. But at the same time, I think a lot of fetal medicine specialists would agree that, we live in an unequal world where there are people who would want to know what is the best method which is available, and withholding information may not be a very great idea. So I completely understand where we are coming from, what is the social status, strata that we are handling. And if we go by the recommendations, of course, I will not offer at this particular stage because ACOG says as a secondary screen. But it's also my job to tell them that, okay, look, there is a test which is available, which can tell you about the best detection rate for the 5 markers, and that is a test. So I think all of you would agree. And if you have anything else, anybody would disagree to this or has anything else to say on this?
As Dr. Girish had said that in his center is offering it very commonly for all.
I would agree to that. Yes, Dr. Manish.
Sir, madam, the previous question that you had terminated the baby at very early gestational age without confirming. I had witnessed my presentation with Professor Kaifros when he was in Delhi. We are sitting the same stage. In front of audience, he has apologized that because of that false habit, at that time, Vaccine screening was only 1 millimeter. So if more than 3 millimeter knuckle, echogenic focus in heart, people are terminating. So it said that to write the report is not important. To understand the patient, what is the report, that is most common. Second, when we are talking about NIPT, NIPT is new to us. But if you see the history of NIPT, it starts from 1959, when first fetal cell was seen in the maternal blood. Then 69, 2019, it has picked up. Professor Mechar was there in Dr. Ashok Khurana's conference, and he has told that now it has stopped NT and NB. They are doing only NIPT.
We'll come to that question. Sir, we'll come to that question. Leave that question now. So let's move on. So I would now say, I will ask that question to you. Don't worry, I'm not going to leave you at that. Right? Okay. So now my question is that to Dr. Shilpa, that what is the role of biochemistry in the era of NIPT? NIPT is so good, it is 99%. So why should you even do a biochemistry, right? So that is the question, if patient is affording. And this is why I'm asking these controversial questions, because, screening for aneuploidy, everybody does, right? So this is why the question I am asking is, Dr. Shilpa, can we have your opinion?
Ma'am, biochemistry not only helps in diagnosing T21, but also in trisomy 18 and 13 also. So many of even the fetal heart rate, if the fetal heart rate is above the normal, we can diagnose T13 also. So
here we are talking about biochemistry.
Yeah, biochemistry, like if we are doing the PAPI and the beta HCG, the PAPI increases normally in a pregnancy by about 3 to 4 fold every 5 days. But in trisomy 21 and in all other problems, the PAPI doesn't increase to that level. So that shows that there's some problem in the placenta. So not only this, it also helps in diagnosing other problems, the biochemistry one, and it also helps in T13 and T18 also.
So Dr. Shilpa, I think what you're saying is correct in the sense that, when you are actually not doing a biochemistry, the chances that you are missing other chromosomal abnormality beyond 13 and 18 are also there, right? Say, for example, this paper talks about, Hu et al., Norton et al. They said that the residual chromosomal abnormality is more with cell-free DNA. Right. It is slightly more. So it is a possibility that if you are testing, because, this chromosomes, this FTS is looking at the whole biochemistry, while CFDNA is targeted at 5 chromosomes. So you might have other chromosomal abnormality, which you are missing if you are not doing biochemistry and just doing a targeted DNA, CFDNA. But of course, the significance is not too much, So it all depends on our counseling. So there is some proportion who you might be leaving. So the practice point, which ACOG also says, that if a patient chooses screening, only one screening approach should be advised. So if you're choosing FTS, don't do cell-free DNA. And if you're doing cell-free DNA, don't do FTS, because it's neither cost effective nor, and if you have discordant results, then it can be more distressing to the patient than one of them, and screen positive results analyzed followed by a reassuring cell-free DNA. So if you have a first screening test and you have some doubt, then you do a better screening test and then you have an answer in your mind. So don't do everything simultaneously. But yes, if the patient is a low risk patient, you have everything is about numbers, and you tell them that, okay, it is 80 to 85% detection rate and you go for FTS. If you only want 5, you have a 99 with cell-free DNA. So tell the patient, counsel the patient, and then whatever the patient chooses.
Ma'am, can I add something here?
Yes, please.
Last webinar, we were with Dr. Divya Singh. She's one of my, she's one of the faculties who's teaching us. And she said that cell-free DNA technique is most sensitive and specifically for trisomy 21. Not
13
so
and 18.
for 18 and 13. So if you're doing it for trisomy 21 detection, and if NIPT is positive, it's basically you cannot take an action, but it's NIPT positive for trisomy 21 really has a value, but not so much for 13 and 18. Your comments, please.
Yes. So basically, whenever NIPT is positive, there is a chance that, it may be false positive, because the positive predictive value is low. So we'll come to that question. What do you do when NIPT is positive? You will have to confirm. But if the NIPT is negative, that is what is reassuring, that your baby is okay. But then again, the detection rates for 21, it is 99. And for 13 and 18, it is between 95 to 97. So whatever, when we do fetal medicine, we have to be mathematicians. Please remember, we talk in numbers, you document in numbers so that we are safe. We told you, this is the detection rate, that 5% I told you before only. That's what we need to tell them every time. Detection rate is 85%, detection rate is 99%. I don't know about that 1%. You have to understand that. So I think those numbers are very important, right? So with that, we come to this very simple question for Dr. Urvi. Now she's 39-year-old, right? So she again at 12 weeks. Now, do you think you would be likely to do more NIPT than FTS? And why not FTS at this stage?
Ma'am, if affordability is not the issue, then definitely NIPT, because of the age being the factor that she is above 35 years old. So when she does come to me, I would do her ultrasound. And if I don't find any abnormal finding, I would give her the option. See, these are the numbers. This is what serum biochemistry would give me this much detection.
My specific question to you is that if you do serum biochemistry at this stage, what is the problem? Generally, that's my, why I discourage from doing FTS at nobody says no to anything, right? There is no absolute contraindication, but I would slightly not want to do FTS at this stage. Why?
Because factor, ma'am, because it will come in high risk or intermediate risk.
Yes, it will come high risk because of the age, and then you go on testing more.
Yes.
Right? And then the patient goes through this cycle of NIPT or invasive testing. फिर वो बोलेंगे नहीं मेरे को कोई doubt नहीं चाहिए, आप मेरा पहले CVS कर दो, amnio कर दो. इससे अच्छा पहले ही NIPT offer करो, so that you're clear in first stage. Right? So that's why the concept of doing NIPT for women who are in advanced maternal age comes, because the age risk of FTS becomes very high and the false positivity becomes high. So I think that's one of the important aspects where we discuss this, that NIPT is little more likely to be recommended when the woman is more than 35 years of age. And of course, the position of NIPT is very clear when you have an intermediate risk, or, even in a high risk when the patient doesn't do testing, then also you can go for NIPT. Now the question, although this question is for Dr. Akashi, we'll come back to Dr. Manish, we'll not leave you on that. But what is the role of NT in the era of NIPT? A lot of people would have. So I think I read this quote somewhere that we took years and years to do a good NT, to learn to do a good NT. Don't give it up for a blood test, right? So now what is the role of NT in the era of NIPT, Dr. Akashi?
So, ma'am, I think NT is like a primary USG marker to assess the risk for any risk for chromosomal abnormality. So it is a very sensitive marker as well. And performing NIPT alone has a potential risk of missing severe structural abnormalities. So I think combined screening method would be very useful, like doing NT scan and based on the scanning results, offering NIPT or any other test.
So you are not the one to give up on NT anytime soon,
Can I
right?
speak something?
You're not, Akashi, you're not going to give up on NT scan.
No, ma'am. I think NT would be a very strong marker for deciding whether which test we are supposed to go for screening.
Absolutely, absolutely. So, yes, I think Dr. Monica and then Dr. Manish, quick comments, please, because we have
Yes,
lots
ma'am.
to discuss. Yeah.
And because just now we had a talk and we were told that if NT in the first trimester is more than 3 or more than 3.5 mm, all screening tests should be thrown out of the window.
Yes, so we'll
So
come to that
basically,
raised
yeah,
NT
so-
point. So that's a
so
very good
NT
valid point that is taken, but no raised NT, normal NT. Okay. Right? So anything else, Dr. Manish, you'd like to add?
Madam, now you see the per speculum examination is lost art in obstetrics and gynecology.
Yes, yes.
After having transvaginal ultrasound.
Yeah.
So we have to teach our student that you have to see cervix through the speculum also.
Yeah, yes.
Like that, when NT came or NIPT came, there is lots of discussion. Worldwide, in Australia, they had thrown NT into the dustbin, just like torch test has been thrown into the dustbin. When previously are doing torch test. So
Yes.
it is the evaluation of things from 69 to 2023. You see, NIPT has evolved like anything. Number one, there is nowadays extended NIPT also.
No, sir, we'll discuss that. But here the point is, would you still consider
Point
it?
is, no, I will do NT, I will do serum marker, and if it is required, I will do NIPT for my Indian patients. I will not jump directly into the NIPT because everybody is doing this. When it is free from government, when it is a mandatory by the government, then people are doing NIPT as a first screening test because they don't want any anomalous child in their community. But pertaining to India, किसी का महल देख के मैं अपना झुपड़ा नहीं जलाऊंगा.
Agreed, sir. So you will say that NT has a role even in this era of NIPT.
Absolutely,
NT
madam.
cannot be. NT has a rock solid foundation, and
Rock solid foundation.
Interesting finding is that if you actually go for ultrasound before doing any testing, you will find that 16 to 20% of the people, like what Dr. Monica said, is that you will have to change your screening strategy. You will not go for FTS. You will not go for NIPT. You will probably need an invasive testing, or there would be some other thing which would decide whether what test you want to do. So one is that. And the second, of course, it's that it's a mini anomaly scan with the kind of machines and the man behind the machines that we are having. We can actually detect so many more things. So we cannot lose that window of doing an NT. And 34% of the fetal congenital abnormalities would be missed in the first trimester if we don't do that scan. So really not worth even thinking that NT can be replaced by NIPT. So I think we can just let it be at this point of time. And in the ISWA guidelines in 2017, almost 6 years back, said that it should be offered first trimester scan regardless of their intention to undergo CFDNA. So ISWA has been very, very mature 6 years back as usual. And I think we should stand by it. So now the next question is that she's 26-year-old. The first trimester scan showed an intermediate risk, right? And the NIPT had a high risk for Turner's. I think, Dr. Monica, you wanted to ask this question, right? And this was actually a real case, which we followed it up. And so just to talk about why I put this here is that NIPT is not as good for Turner's and, XY and 1813 as it is good for 21. So what would be the next step in management? So this is an NIPT which is positive. So how would you manage this? What would you do, Dr. Manish?
If suppose the gestational age is around, because we had done this NIPT in early gestation, 8 to 10 weeks, then I will definitely go for CVS.
Yeah.
Because then I want confirmation. Confirmation that I will get by karyotyping is at most important rather than doing any random test. So if there is a XO, I will go for CVS. And if C has gone more than 14 or 16 weeks, then I will go for amniocentesis. No doubt.
Right. So you want to stress upon the fact that NIPT is not the basis for management. It should be confirmed by a confirmatory test. It can be a CVS or an amnio. And this is what the table is showing, that the best detection rate is for 21. And for monosomy, it actually comes down to less than 90%. So it might be false positive, right? You don't know. It might be actually a Turner mosaic mother, right? Who's having, she's Turner mosaic, and we had a patient who's actually Turner mosaic. So, and she's carrying that fetus. So it can be false positive, and that's why you need to confirm it. So that's the message here from this case, is that even if NIPT is positive, do not take any irrevocable decisions based only on NIPT. You need an invasive testing, either CVS, like Dr. Manish said, if it's early pregnancy, or amniocentesis if it is late pregnancy, right? Now we move on to the next case, which is she's a 23-weeker, second gravida para 1 live 1, first trimester screen, NT-NB was okay, dual marker was not run. When the quad was done, it came to be high risk for T21. So NIPT was done, and it was also high risk for T21, and an amniocentesis was done for her. So as decided, it was high risk. So now the question is, now the patient is very, very hyper, and this is what we were discussing. So what is the positive predictive value? So the patient is saying, hey Bhagwan, mera to double marker, quad bhi positive hai, NIPT bhi positive hai, ab to mera bachcha affected hai, I will take the pregnancy. The question is why, and what are the chances that the baby is actually affected if your NIPT is positive? So Dr. Monica, could you tell us that what is the positive predictive value of NIPT? That screen positive does not mean affection. So there is a positive predictive value for every test, and that is what in numbers you should tell even before counseling, so that they do not terminate a pregnancy based on screen positive.
Yes, ma'am, you were very right that all fetal medicine specialists have to start from mathematics. And so positive predictive value is actually a ratio. It is the proportion of the true positives out of all the false positive and true positives. So true positives divided by all positives, false and true, makes up the positive predictive value. And if any test which has got a high positive predictive value is a reliable test. Yes. Because it is sifting the true positives out of the total bunch of positives.
Right.
And ideal
So,
would be
madam, you have
100%.
to become
Ideal
a
would be 100%.
specialist
Yes.
again.
So, but at the same time, we do understand that because the positive predictive value is not 100% for an IPT, there is a huge chance that the baby might be normal, right? So this is what we need to say, that if it's a low risk pregnancy, like a 20-year-old, the positive predictive value is quite low. It actually is between 40 to 50% on an average. So 50% chance that the baby might be normal, even if the NIPT is positive. This is the message that we want to discuss here, that even if your NIPT is positive, do not terminate the pregnancy without testing further, because the positive predictive value is low. But if you have an elderly woman and 40 years, the chances that your baby is affected is quite high. So the test performs based on the background risk. So if you have a high risk population, the positive predictive value is high, right? And if you have a low risk woman, so this is also called the odds of being affected given a positive result, which is the OAPR, right? So if you see the OAPR, it is quite high, 1 in 20 if you have a high risk population, but it is lower if you have 1 in 20 for a low risk and 1 in 5 for a high risk. So this is what the numbers, when you talk about to the patient and you tell them that this is the situation, let us test you further. And this is the reason why. So there are reasons: mosaicism, vanishing twin, maternal sex abnormality. And if your result is negative, the patient should still be offered 18 to 20 week scan and the usual follow-up. It is reassuring. The result is negative, it is reassuring. Now, Dr. Usha, now this NIPT, sometimes it comes as inconclusive, and that I'm not able to give you the result. Now that's another patient is left in a Trishanku wala swarg type. Now upar hai na niche hai. So ab kya karenge? Dr. Usha, can you tell us, like, what would you do in that situation?
I think we should, that company is also offering repeat NIPT testing. So again, one repeat NIPT test.
Would you go for repeat in all, or you would decide, okay, this I repeat, this I go for amnio?
Okay. If no, like double marker, I mean combined screening is coming in low risk.
Yeah.
Then we can repeat. If it is coming in high risk or intermediate risk, then we can high risk or intermediate risk, then we can go for invasive testing.
Right. So the point here is that why did the test fail? Okay, is that actually a technical problem, or it failed because the baby had aneuploidy and the fetal fraction was low? So there you have to balance that risk. So like you said, if the background risk was high, right, the age is advanced, there is an ultrasound probably finding, or there is further ultrasound and counseling the patient and advanced gestation. So in that case, you would probably not want to repeat the test and go directly for an invasive testing because you're wasting more time. But if suppose it is not like that, it's an early gestation, you have time and there is nothing else which suggests an aneuploidy, low risk patient, ultrasound absolutely normal. In that case, you would say, because actually the studies have shown that 3% raised, if you look at the population in which the test had failed, the prevalence of aneuploidy was more around 3% versus 0.4 in the overall cohort. So a failure increases the risk of aneuploidy, and we keep that in mind. And we look at the gestation, the background risk, and then we decide whether you want to go for a repeat testing or you want to go for a direct invasive testing, right? So the ACMG 2016 says that offer diagnostic testing if no call for NIPS, but you can you can decide in consultation with your geneticist, take the patient risk, take the background, take the gestational age, and then you decide what you want to do. Now, what Dr. Manish was saying, Dr. Manish really looks into the history of NIPT, but Dr. Ishrat, would you like to talk about, do you do an standard NIPT in your practice? And is there a current role of NIPT?
Currently, basically, ma'am, through your question only, I get to know about the expanded NIPT, then I search the literature itself. Basically, as per lot many literatures and lot many evidences say that the NIPT is per se highly sensitive for Down syndrome, for T21. But the sensitivity for other things is not, and the positive predictive value is not that high. In current scenario, when we don't have more of the evidence, so I would not recommend, but definitely expanded NIPTs have increased.
Your network is poor.
Maybe.
We can hear you.
Okay. Because expanded NIPT, because we wanted to avoid the invasive testing. So, and the patients which are really wanted to know that my baby is really fine. So we can counsel accordingly that it detects other microdeletion, duplication, and further chromosomal, autosomal diseases. So we can really offer, but in present scenario and for Indian scenario, I would definitely not.
Yeah, I would agree that right now we are not there as yet, right? So it is a double-edged sword. The genetic testing, the more you do, the more you don't know what you're doing, right? So we have to be very careful. Right now, a lot of companies would say and come up and say microdeletion testing. And in fact, a whole chromosome testing also they are being offered. But let's wait and watch. As per the current recommendation, we have to offer NIPT for the 5 chromosomes as per the current recommendation. But of course, we are looking to the future when we are also looking forward when any non-invasive testing would be validated and available for practice. Right now, it is not. Yes, Dr. Manish.
Yes, madam. Now it is evolving that now the Professor Suresh has taken representation on this NIPT extended, that now NGS has came.
Yes.
Non-sequential that method, and now they are screening all the chromosomes. So it is not a far future, but we can diagnose more with NIPT, but it is now at present in experimental stage. But then next, now madam, every cancer is also detected in utero. That is a genetic transformation because we are carrying that cancer gene.
Maybe
so
1 year
now,
after this,
in the era of genetics, so extended has got definite role, but in future it will become a routine for us.
Yes. So right now, not recommended, but yes, we are looking forward to validation studies where we can say that, okay, now it has been accepted, but right now it is not there. So Dr. Ruchi, I would like to know, this lady has a NT of 2.5 with a CRL of 77. So what is the next step that you would like to do?
Is there Dr. Ruchi?
Oh, sorry. I'm so sorry. Yes. Akashi, you can
I think, so there's Akashi and Urvi and yes.
Yes. Am I missing somebody? Have I not asked the question to anybody? I'm so sorry because I don't know. Have I missed some question to somebody?
Dr. Urvi, ma'am.
Dr. Urvi. No, I asked, Dr. Urvi question was asked.
Everybody has taken one round.
So Dr. Akashi, you can answer this question, yes.
Ma'am, is it okay if you can repeat the?
So the question is just this, like, you get this thing that you're doing a scan and this NT has come to be 2.5 on a CRL of 77. So what is your next reflex? Like, how do you know and what do you do? So it's a very simple thing that, the point here that I'm trying to make.
Nomograms.
Yes. So we would like to talk about the nomograms, right?
Nomogram.
Yeah. So anybody would like to talk about it?
Yeah. So if the combined risk is coming into a low risk category, so yeah, we can offer them NIPS as first line of testing because she is 19 years old.
Yeah.
And yeah, I think that would be.
So actually don't get confused. The simple question that I wanted to ask is that NT in an absolute value, which is less than 3 mm, has to be plotted on the
nomogram.
On the nomogram.
If nomograms goes more than 99th percentile, then we have to think of, you can do repeat scan so many times, 2.5 to 2.7 knuckle may be normal for that particular patient.
So the same 2.5, if the CRL is 54, say for example, the value is the same, but the CRL is 54.
54, then it is coming in high risk.
Yes. Then the
So you
centile.
have to plot according to the crown rump length and see that whether it is coming in a speculated area, then wait. If it is going above the 99th percentile, then you have to go for either double marker or invasive testing. Never jump directly onto the NT measurement only.
Right. So if suppose now my question is, so I think I'll take Dr. Manish on that, right? I'll ask him if your NT is more than the 99th centile. Okay, so if your NT is more than the 99th centile, Acha, Dr. Shilpa has this question. Okay, maybe we come back to you after Dr. Shilpa has answered.
No problem.
And if you have anything else to add. What is the approach to the raised NT? And a little bit of rhasopathies, because we're talking so much about rhasopathies these days. So just to add a little bit of extra things to that. But what is your approach to raised NT?
From any NT which is above the 95th percentile for that gestational age has to be investigated, not only for the trisomies, triploides, but there can be any cardiac problem, major cardiac defects, and there can be any connective tissue disorders, but even genetic mutations that can be hiding. So rhasopathies are for the genetic mutations, and the most common one is the Noonan syndrome.
Right.
So again, in Noonan syndrome, there is a pulmonary valve stenosis. So even if we can detect it, raised NT is again a problem. Even the baby can have sudden IUFDs are known. So we have to be very careful in any raised NT, and it will disappear after 14 weeks. So you have to be careful. You have to investigate in all possible ways.
Right. So if it is a raised NT, would you offer NIPT?
NIPT may help me to diagnose, and if I get something and I'm conclusive, I'll go for amniocentesis. If I don't get anything, still I have to keep it in my mind. I have to go for the targeted sonogram at 18 to 20 weeks. And after having completely normal at 18 to 20 weeks, then only we can make the patient out of it. Otherwise, raised NT can be normal in 5% of patients.
Yeah, absolutely. So my question is also to the other panel. Yes.
One thing is very clear. Whenever you see raised NT, there are two buttons. One is panic button and one is patient button. So never get panic unless and until you get more than 95th or 99th percentile. Don't make yourself panic and make another patient panic.
Okay, so is it okay if I panic after the 99th centile?
Then I have to go for either double marker, or I have to go for NIPT, or I have to go to all invasive tests.
That is the question I want to ask, sir. That is the question I want to ask. If
Madam, I'm very clear about this. Above the 99th centile, I will go for invasive.
Yes. Yes. I want to, highlight on that matter that raised NT is a structural marker.
Yes.
Yeah.
Okay, so let us again reinforce this fact that raised NT is a structural marker. It is not just a marker for aneuploidy and 21 and you must not, I cannot say in fetal medicine that you must not. There is no must not, right? There is no absolute contraindication for anything, but you have to know your numbers. What will happen if you offer NIPT to a raised NT? is what is the risk of residual genetic syndromes that you are leaving behind if you offer NIPT to a raised NT. So that proportion is definitely much higher, right? So the point here is that if you have the NT more than 99 centile, let us make this a practice point that I will go for invasive testing rather than going for NIPT. So this point.
Madam, make Oscar Clinic, one-step solution for aneuploidy screening. Dr. Suresh is doing Oscar Clinic.
Yes.
Oscar. So one-step solution.
Agreed. So the point here is that if you have a raised NT and you have done the QF-PCR conventional karyotype and nothing has come, then you also go for microarray. So why all of this important is that NT is a structural marker. You have to look beyond aneuploidy to look for chromosomal microarray. And if all of them is normal, you have to also rule out any cardiac anomaly. And then if everything remains normal, then you have to test for other genetic syndromes. But it is also seen that the bigger the NT, the more are the chances of rasopathy. So if you have an NT which is more than 5, or you have an NT which is more than 3.5 with other features like jugular lymph sacs, hydrops fetalis, pleural effusion, ascites, cardiac defects, then you can also initiate genetic testing in the initial part where you are actually doing the testing in the initial part. So there are certain features and they have shown to be very, very accurate kind of thing when you are looking for NT and you're doing an ultrasound. So a definitely raised NT beyond 5, you have a very high risk of some genetic. Between 3.5 to 5, there are associated ultrasound features, again, chances that you have a rasopathy. So need to look into it. I think there's a few things about interpretation of biochemistry, and this is very, very important, and I find it very interesting. So you look at this patient, she has an age risk, which is 36-year-old. She has an age risk of 100 and 192. By biochemistry, so you see by biochemistry alone, she came to be 1 in 145. But overall, the risk of trisomy 21 is 1 in 830, right? So this is her. But in the entire scenario, what we have to see also is that she was a primee at 36 years, conceived by a donor IVF with a vanishing twin, and now at 14 weeks. So the entire meaning of this thing is null and void. So the entire interpretation. Yes. So the age is of the donor, ages of the donor, the IVF has not been marked here, right? And it's a vanishing twin when biochemistry is not even allowed. So the point of doing in the light of this, what are the relevant details? And I would ask Dr. Monica to talk about this. I think the name is probably not right again. So Dr. Monica.
Yes, ma'am.
You again want to emphasize the importance of, noting down the details.
Ma'am, like when I do, these maternal serum screening for my IVF patients, I make it a point. Nowadays, the ART law is there. So this donor and everything has come in the ART bank scenario, but otherwise it is the age of the donor which has to be specified as the age of the sample woman. Secondly, you have to take into account the background risk will become the background risk of the donor. Now, if you have transferred 2 or 3 embryos and you have a definite history of a vanishing twin, then definitely this serum analyte will not give us the correct report, because in twins, biochemistry is erroneous. For twins, NIPS would be a better option.
Yes.
For many reasons. And this is the error in the report, madam.
Right. So essentially why I've picked up this report is that we have to be very careful when we are sending a biochemistry, because unless we send the biochemistry properly, we are in a mess, because we keep on interpreting the biochemistry wrongly and it adds to the anxiety of the patient. And then we end up doing an invasive testing for nothing, because otherwise there is no other way we can actually relieve the anxiety of the patient. So it's very important to look at the age of the mother, gestational age, previous history, and you adjust the moms according to weight, ethnicity, ART, twins, diabetes, smoking. So it is our responsibility when we are sending the test that all of these things should be noted, and we talk about it. So I would like to ask Dr. Urvi here, what is the role of expanded first trimester biochemistry right? So are you doing it? What is your impression about the expanded first trimester biochemistry?
Yeah, ma'am, it does help in getting us to the higher detection rates of other conditions, like especially preeclampsia, where PLGF has been put into in the addition of the first trimester screening. But yeah, it's the counseling part actually. Some patients are accepted towards it, so they will agree to it, because many, the patients who I am catering to right now are still hesitant about NIPS. So coming towards PLGF and other factors is still a couple of steps still away for me to actually convince them that even through these markers in first trimester will help the certain, help us throughout in the rest of the pregnancy.
Right. I agree with you. Anybody else would, say something? Because, what I personally feel is, it's if somebody is getting a dual marker done, and for the same cost, if you can ask the lab to do a PLGF, why will you not get a PLGF done?
Exactly. I would like to
Definitely, even the screening for the early preeclampsia, we can start with the ecosprin. It would save a patient developing in the early onset preeclampsia. So definitely, it's a good approach for expanding.
And I would also say that, we are all fetal medicine specialists, but our responsibility is also to see the mother first, right? And preeclampsia is one of the biggest killers of the mother. So I think when we are looking at the baby for aneuploidy, our responsibility to look at the mother for preeclampsia. So I think
it becomes a moral responsibility. It becomes a moral responsibility on part of us to test for placental growth factor inhibin A. In fact, I was going through a very reputed fetal medicine center's website, ma'am, and they said, we will inform you these tests within 10 days by email. It is their duty to inform by email so that their obstetrician can start the ecosprin, warn the patient about the risk, and in a month they'll get the hard copies. So, ma'am, it is imperative
for all practical purposes, I practice in a government setup, but if possible, I inform them that, see, this is an additional cost or not, because we do the dual marker inside the hospital. But this is an additional cost. It's up to you whether you want to do it or not. But something that we need to take it up as fetal medicine people, because we are seeing women at that gestation. So I think it's our responsibility to talk about this, right? So I think this is the last question that is there for us, is the ideal method for screening. I think second last, but I think we can just finish it here. Ideal method for screening in twins, Dr. Akashi.
So, ma'am, I think there is no ideal method for screening twin pregnancies, because it is not as accurate as it is in singleton. But however, combined screening has shown detection rate of 89%. So I think for twin pregnancies, I would go for combined screening. But
so you will go for a nuchal translucency with dual marker, which is very good. I think it is completely accepted that you can go for a FTS, first trimester screening in twins. So all of the guidelines, they do advise a first trimester screening. So without fail, all of them say that you can do a first trimester screening. Only NICE says that you can probably do a quadruple, but none of the others say you can do a quadruple. So I think first trimester screening, we all do, we all offer. What about NIPT? Can you do, can you not do NIPT in twins?
We can. It has shown a very good detection rate, but it has possible false positive results as well. So
I think NIPT is very good in twins, madam, because NIPT will give you, if there's any doubt or if the ultrasound has been done, fetal parts are crowded, it gives a fair idea of the zygosity also. Because each fetal DNA of both the twins, the genomic differentiation is there.
I don't think they use it for that, but yes, I mean, NIPT in twins is absolutely good, and we must use it if it is required. So there's no confusion about it. Yeah, thank you. So I think that is there. And the last question for Dr. Manish is, after this we vanish. What is about the vanishing twin?
Madam, if we see vanishing, it is seen on ultrasound, but in utero, it is not vanished. It's still sending some dead cell or signaling into the circulation, and it will give false positive report. So vanishing is vanishing for us, but not vanishing in utero. So to think in that.
Yes. So essentially the problem is that once suppose a fetal pole or a cardiac activity comes, it will stay for 8 weeks. Yeah. So anything which happens after 5 weeks and 8 weeks, so you cannot offer, it becomes 13 weeks, right? So you cannot offer a first trimester biochemistry. Similarly, cfDNA has been seen to persist for around 15 weeks. So if you want to do a cell-free DNA, you will have to do it after to 20 weeks if you want to do a screening with the cell-free DNA. So problem in vanishing twin is not the beta HCG, but it's the PAP-A, which continues to, stay for a long time. Beta HCG can go away, but the PAP-A stays. So either you have a specific PAP-A for beta HCG, otherwise you cannot handle it. So I think, ma'am, Dr. Monica, do we have time to do this last case, or we end the panel here? Can't hear.
Oh, ma'am, you can do the last case. Please go
Right.
ahead. Yes.
So there is this patient who's a first trimester low risk, okay, and she had an absent nasal bone, echogenic bowel, and a muscular VSD. So this was a case we recently had, and multiple soft markers. So Dr. Monica, how would you go about this? What do you do in your routine practice for soft markers? Dr. Monica?
Yes, ma'am. Ma'am, I'm there. She has had a level 2 scan.
Yes.
Means
So she's around 18 weeks.
Yeah, her first trimester screen was low risk.
Yeah.
Then in level 2, she had multiple soft markers.
Yeah.
And ma'am, I would go for an amnio, I think. Because no, it's absent nasal bone, echogenic bowel, and muscular VSD. Yes, ma'am, I would, because I don't think any other screening test would be.
You will not go for NIPT?
No.
And
multiple marker, like more than 2 marker if present, I think better is to go for invasive. Even isolated single marker might give the scope of further screening test. But,
isolated soft marker like absent nasal bone, not very significant. But
yes, but the combined 2 to 3 markers are together, no? So I think we should go better for the invasive.
Ma'am, I think I'll go for amnio, but I would like other experts, Manish sir can.
There are gray zones in ultrasound, because previously we are doing gray zone ultrasound. So this is isolated marker, isolated absent nasal bone, isolated nasal thickness, isolated echogenic bowel. Then we have to do re-evaluation of ultrasound and then go for subjective testing. One isolated marker per se doesn't say it is a trisomy.
Absolutely.
One isolated marker doesn't say per se it is a trisomy. See, isolated echogenic focus in heart. People had started mentioning. Now people is now not mentioning because patient has got panic button. Heart ke andar kuch mass hai. But it is isolated. Just wait for it.
Yeah. So I think very true. So there are 2 scenarios: isolated, multiple. Okay.
Yeah.
So now isolated में भी कुछ soft markers ऐसे होते हैं जो soft होते हैं, जो बेकार वाले soft marker होते हैं ना, और जो कुछ होते हैं जो actually वाले होते हैं. ठीक है. So जैसे ये हैं isolated EICF अगर है, and uska, if you have had no previous aneuploidy screening, then you have to offer some aneuploidy screening for the purpose of offering aneuploidy screening, not for EICF. If all of these have had a previous serum negative or a previous CF-DNA result, you don't have to do anything if these are isolated, right? So EICF hai, previous quad negative hai, previous FTS negative hai, or for some reason you have a CF-DNA, then we don't do anything. But there are certain things about echogenic bowel where you have to think about CMV, fetal infection. If it is an isolated pylectasis, then you need 1 scan at 32 weeks. For EICF, for God's sake, let us not do a fetal echo. We are doing a fetal echo as a part of scanning. But fetal, so EICF, I think, is one of the biggest nuisance that has emerged in the recent times. So we need not give it too much importance in terms of isolated EICF. So if there is some previous screening which is available, there has to be no further aneuploidy evaluation. So we have to be very clear. But there are 2 things which are more important, like thickened nuchal fold and hypoplastic nasal bone. So these are like the harder soft markers, not the softer soft markers. So when you have these harder soft markers, then you have to offer some further testing if there has been no previous testing. Even if there has been a previous testing, then you can offer further testing, because these are a little strong markers to indicate aneuploidy. But if there is a NIPT which is negative, then you can let it be. So this is something which is important. Now, CPCs, again, nuisance value. If you've had a negative serum testing, forget about it. Don't do anything. If there has been no previous testing, you offer some aneuploidy screening for the purpose of offering aneuploidy screening for pregnancy, if not for anything else, not for CPC. So there is a 3-step approach to soft markers. If you find one soft marker, search for other soft markers
Another.
and do a structural approach. Calculate the risk of trisomy. Now, if you have multiple soft markers, this is what we do. Calculate the risk of trisomy based on the likelihood ratios and a background risk, which is based on the maternal age alone, or a combined screening or a quadruple screening, which you have done. And that likelihood ratio you can calculate from the calculators which are available online by the meta-analysis of Agathocleos or by a perinatology.com. And then when you calculate the final risk, if the final risk is less than 1 in 250, then you leave her alone. If it is more than 250, you do further testing. But it has been seen, and that is why Dr. Ishrat was saying that if you have multiple markers, this risk when you calculate will come to be higher only. Generally, it ends up being higher. So that's how you end up testing. But as a rule of thumb, if you have multiple markers, we would prefer to test rather than leave. So this is your LR ratio. So if you have an isolated, then you take these LR ratios. If you have multiple, you have to multiply by the positive and divide by the negative LR ratios. All of this is maths. All of calculators are there. Nothing to worry, but these calculations have to be given to look for other markers, optimal a priori risk assessment, and calculate the final risk. So to give and then decide regarding further testing. Now this lady, because she had multiple markers, she turned out to be, we did an amniocentesis and she was trisomy 21 positive, as was expected. So we did a risk calculation, came out to be higher, and we did further testing, and then this pregnancy was terminated. So I think that is all I would like to talk about. So the ideal first trimester screening is combined test. Do not repeat a high risk report. I think this is one of the worst things that we do is patient ka high risk aa gaya, wo khush nahi hai, dusri jagah se biochemistry ka hai. So no two biochemistries should be done. NIPT can be offered as a secondary screening. Invasive tests can be offered for high risk screening reports after proper counseling. So I think this was the desirable protocol for first trimester. You do a first trimester screening, FTS more than 250, offer testing. If it is screen low, away from the discharge protocol. If it is intermediate testing, then you do further. If it is intermediate risk, then you do further testing, which can be NIPT. And if you can integrate the first and the second trimester analytes, if it is possible, then you calculate the new risk. If the patient has not come in the first trimester at all, then you offer a quadruple. If the screen is positive, offer further testing, screen negative, then you discharge from protocol. So I think thanks a lot to the esteemed panelists, and thank you organizers for having me here. Thank you very much.
Thank you so much, Aparna ma'am. I mean, Dr. Girish spoke so highly about you. You are not the high, you are the Mount Everest of fetal medicine, and you've taken this panel forward so seamlessly, so beautifully. Even I was so scared, I'll be, asked questions, but even I could manage because you were the ideal moderator. You were not harsh. You were not soft. You were the right soft marker.
Little bit soft, and little bit soft.
Added soft and soft.
Ma'am, are you joining?
Madam, one thing that we have forget our PSM, preventive and social medicine, priori risk, false positive, false negative, how to calculate the risk. So it is a first and foremost important thing in fetal medicine to know how to do how to become a statistician, calculate and interpret our result to the patients in that positive way. So thank you very much for moderating the session. And
Manish sir, just a minute. Manish sir, Dr. Nandita Palshetkar is joining us for 1 minute.
That's good. That's good.
Yes. President Isar is joining us. She just called me that I'm free right now. Can I join, or have you done? Manikani ma'am, please come and say a few words. And all of us know that all of us would like to listen to these lectures once again. We would like to listen to Dr. Mayank's lecture, Dr. Girish's lecture, and this panel, because Aparna ma'am's slides, they went so fast, cut. So we would like to see them properly again. So everything will be available on YouTube in the next 30 minutes for you to see at leisure. And I think
Nandita ma'am, yeah, request to Nandita ma'am.
Madam has joined.
Just see.
Dr. Randhir, can you call Madam? Has she got the link?
Okay.
I have sent
Okay,
it.
I'll call you. Yeah.
because
So
Dr.
meanwhile, one caution, Monica madam, don't hit the panic button once you see the time slot.
No, no,
Aparna
no.
ma'am, I have one question. In the last case where patient has multiple soft markers, can we go for expanded NIPT?
Not yet validated. I could not do that.
Because once you have got one thinking of trisomy 21, why you want to subject to another? Once we have got once our focus that with all these priority risks, we are going more on side of trisomy 21. Because all this NIPT aneuploidy screening with all these different soft markers is based on trisomy 21. तो आप उसके पास एक मार्कर है तो दूसरे मार्कर को ढूंढो, दूसरा मार्कर है तो तीसरे मार्कर को ढूंढो, सब कजिनों की शादी बनाओ और अल्टीमेटली देखो कि वो कहाँ पे जा रही है.
Okay.
So Dr. Nandita has joined us, President ISAR, and the person because of whom ISAR Perfection Series is where it is today. And Madam, it's so nice of you to join just before we finished our program. And we had a beautiful session. Madam, Dr. Manish Pandya is there, Dr. Aparna Sharma from AIIMS Delhi, and all my Dr. Milind Shah and Dr. Shashi Srivastav and all my colleagues from Bhopal. Intas and Randhir is also there, ma'am.
All my favorite people are there, I think.
Yeah, ma'am. Welcome, ma'am. Welcome.
I think it was nice to hear the passion-filled talk of Manish. You know, arguing.
Yes,
It's really good, and I'm so happy to see all of you all. And congratulations, Monica. I think this series is going wonderfully, and the topics today which you've covered is superb. Good to see Aparna and Milind. Yes.
Hi, Nandita. I just came for all of you, just to meet now because I was silent.
Really nice.
Great.
And it's really good that you're here, and I can see Dr.
But you are looking so younger, Nandita. I could not imagine. You are looking like 90s, Nandita.
ISAR and everything is really
Hi, Manish.
young.
global है, तो young तो दिखना है.
बिल्कुल.
Well, the company of all these youngsters keep me young. Purnima and
Exactly.
Shilpa and Shashi. I think it's
Yes.
really great to have everybody here. And Randhir, how are you?
That's fine, ma'am. Fine.
You know, ऐसा husband होना चाहिए जो इतना supportive हो. I think it's amazing the way. So I think first of all, congratulations. I think I am really very happy that ISAR is doing such a great job. And this was a very, very important topic which you've touched upon, Monica, because I think our job doesn't end by just getting people pregnant. I think giving a healthy baby is very, very important. And this aspect of the, of our obstetrics is extremely important. And I'm glad that we are here to inform and to teach our people that what are the different tests available and how we can help our patients. So congratulations, all of you all once more. And it's always a vibrant platform, I think, which is there, which is available to you all. And I'm so happy that it's been made use of, and so much knowledge is being, passed on to everybody. So congratulations once again, Monica and Randhir. And I'm sure Sunita also did a wonderful job. I saw that, her name in the brochure. So fantastic job. Congratulations.
I'm Sunita Madam, delivered a very beautiful talk on the inverted pyramid of antenatal care, and that started the ball rolling.
Right.
And ma'am, I remember, ma'am, 1.5 months back, I got a phone call 7 a.m. Nandita Madam. Monica, why are you so upset? What do you want to do? You want to do is Perfection Series? Do with ISAR. I mean, she just said it, do with ISAR. And that started all this. Madam, I'm so indebted to you.
No, I'm also happy that it's going
You're
on.
You're a beautiful person in and out, madam.
Thank you. Thank you. Okay, sorry I could not join at the beginning, but I'm happy to see everybody, really.
Thank you.
And we all, on the behalf of ISAR, madam, we welcome everybody to the Global on Conclave from 27-28 on Mumbai.
Yes, I'm looking forward to meeting all of you all.
Yes, coming, madam.
And Monica, you have to present the report. And Milind, actually, Milind and me go back, I was just remembering 30 years ago. We have been in Foxy for 30 years, Milind.
Yes, our first talk was remember na Guntur and Vijayawada and Hyderabad.
Yeah.
Great. Yeah.
We've traveled so
And-
much together.
Yeah.
Yes.
And Nanita ma'am, Milind sir and Sunita ma'am are the classmates. They are so
Yeah,
so
exactly. We are from
Yeah,
same college.
Oh, you and?
And Sunita ma'am, same college.
Sunita Tandurwadkar, yeah.
Okay. Oh, all
In
right.
fact, I remember Rishi's first ultrasound was done by me. So always remember that, Always tease him that I saw you first.
Fantastic.
Great.
Fantastic. Okay, thank you.
Okay,
so
see you
much.
ma'am. Bye.
for
Thank you
joining, ma'am.
everybody. Thanks.
Thank you, Aparna ma'am. Thank you, Milind sir. Thank you, Manish
Yeah,
sir.
thank you, Monica and Randir and Purnima and everyone. Wonderful. Great.
Thank you, Intar. Thank you, Nandita ma'am, again for joining.
Aparna, great job.
Thank you, Aparna ma'am.
Thank you, ma'am. Nice to see you.
I know.
Yeah,
At
Aparna
such a young
always
age, she's
speaks
doing
very
a
good.
fantastic job.
Thank you,
I know, she's one of my fans.
Okay.
Thank you, Monica
Great.
ma'am and Ranveer sir for giving us.
Bye. Bye,
Thank you,
guys.
Purnima. Thank you. Thank you, Intas.
Thank you.
Thank you.
everyone. Bye, madam.
Bye, ma'am.
Bye, everyone. Good night. Good night. Take care.
Thank you.
Bye. Bye.